Hey everybody, it's Dr. Eric Balcavage. We're back for another edition of Thyroid Answers podcast, and today we have Dr. Miles Nichols today joining us on the podcast. Dr. Nichols, how are you today?
I'm doing great. How are
Hey,
you today?
I'm doing great. Thanks for coming on the podcast. And today we're going to talk about a topic or a couple topics that we haven't really talked about in the past, and that's something called parietal cell antibodies, how they maybe come about, what that means for your physiology. Is there some tie into thyroid physiology with what's going on in the stomach, the gut, parietal cell antibodies, stomach acid? And if time permits, we'll get into a little bit more detail maybe on CIRS and what that is and how that kind of ties into all three of those things. So as I said, Dr. Miles, thanks for being on the podcast. It's always good to have a new topic to discuss, but can you give the listeners a little bit of background on who you are? I mean, you sent me a nice bio and a nice short bio. I like short bios. That's awesome. But people kind of want to know, who's this person who's telling me about something? What's their background? What gives them, why do they have a platform to kind of discuss this stuff? So give us some background about who you are, how you got into the space, so the listeners know who you are.
Yeah, happy to. So growing up, my father was a doctor, and he really did a lot with public health. He did a lot with policy work. He started a rural health office, sent mobile clinics out to underprivileged areas to help get medical care to people who didn't have medical care. He did political work. He was really a mover and a shaker, but he passed on when I was 15, suddenly and unexpectedly, from a heart attack. And that really threw me for a loop and started me down a path of really wanting to understand more about the preventive side of health, more about how we can see that kind of thing coming. And I got really fatigued. I had chronic fatigue in my early 20s. I was really struggling. I was trying to get through school, and I got called into Valerie's office. She was the principal at the school, and she said, you're going to be a great practitioner someday, but you're really struggling to get through this early morning class. Everything else is great. All your grades are great, but this early morning class, what's going on? I said, I don't know. I have a hard time getting out of bed in the morning. It doesn't matter if I go to bed at 9 or 8, or if I get 10 hours of sleep, sometimes I feel more tired, and I don't get it. I'm doing all the things with diet and lifestyle that I know to do. And she said, well, you need to seek some specialists. And so that kind of got a fire under me, and I started I went to a sleep specialist first, who told me that, well, you have delayed circadian rhythm syndrome, which is essentially saying you like to go to sleep later and wake up later than other people. And that didn't really help with the fatigue or the school situation. But my normal doctor said nothing's wrong, maybe you're depressed. And even integrative doctors really didn't have a lot to tell me. And so I managed to get through and get by, but I didn't feel great, and it took really a long time for me to finally find some mentorship in the functional medicine space with a good practitioner who was able to, after countless numbers of naturopaths, integrative practitioners, acupuncture, massage, and even functional practitioners, just took a long time for me to finally realize that my thyroid was off. My TSH was 4, and that was just not flagged in the conventional system. But in the functional system, that's a flag for non-optimal function. And that got me looking a little deeper. And I read some research about H. pylori connecting with thyroid antibodies. So I thought, well, maybe there's something going on in the gut. I had no gut symptoms. Chronic fatigue was really my symptom. So I did a stool test. It was clean. I did a second stool test 3 weeks later and found H. pylori. And I thought, okay, now I'm onto something. I treated that. It helped a little, but not a lot. So I had to keep digging. I found research between SIBO and thyroid issues, small intestine bacterial overgrowth. Tested for that, didn't have that. So went on to continue to research, and there's a lot of elements to what happened, but over time, I eventually discovered that I had parietal cell antibodies, which I know we'll talk about. And that was a big turning point in my treatment. it really made a bigger difference than any of the things that I did direct for thyroid. But we know that 20 to 40% of people with thyroid issues have parietal cell antibodies. So it's related. It's a related condition. And then I found chronic infections, Lyme co-infections, Babesia and Bartonella. And later I found I was living in toxic mold and had to move out. And I had joined a partnership with Dr. Diane Mueller, and we started a practice together. And she was suffering also from Lyme disease and mold illness and several gut issues. And so we really just, out of necessity, spent all our time, energy, and effort trying to figure ourselves out. And that helped us to be able to create a practice, Medicine with Heart Clinic, and be working with people who are struggling with complex chronic issues that have been non-responsive to many different kinds of therapies. And so that's a bit about my journey.
Okay. So I got some questions right off the bat, just listening to the history, right? You say you're saying, hey, I've got chronic fatigue, I've got H. pylori, I've got anti-parietal cell antibodies, I've got mold, I've got Lyme, I got all these things. But at some point we have, and you've seen a bunch of people, nobody's figured out, at some point we have to consider the fact what allowed for those things to occur, right? At what point do you start to say the Lyme is the thing, the mold is the thing, the H. pylori is the thing? Everybody loves the thing theory, like it's this thing. But why would you're in this space.
Yeah.
At what point do you take a step back and say, maybe it's less about the individual thing. Maybe the reason I have chronic issues here with Lyme versus mold or with all these things, did you take a step back and say, what's providing the environment for all of this to thrive? Or did that take a while? Or haven't you got there?
Yeah.
Maybe you haven't gotten there.
Yeah. Everyone wants the smoking gun. And I see it all the time where they want to know what's the root cause, as if it's one. And it's not. It is a constellation, and there are things in the background. And for me, really, I after my father passed, I went into a pretty significant level of internal work and mind work. I became interested in meditation pretty quickly. I got into yoga and Tai Chi and Qigong, and I found out about many different kinds of mindfulness practices, and that propelled me to be interested in looking inside at not only the external of disease and illness, but also the internal space and how that relates, because there's a countless amount of research that's come out now about how simple things like meditation can impact the immune system, how emotional dysregulation and trauma and adverse childhood experiences, the big ACEs study showing these adverse childhood experiences can set the stage, can create those conditions for later an onset of disease. For example, autoimmunity becomes double or higher the chance after a certain number of adverse childhood experiences. And so there's some aspect that I began to, in this process, tune into about that these physical disease processes are in part a cause, and there's an internal part, and there's an environmental and a lifestyle part. It's both a mental, emotional, internal space, a relational space, because I started to read research on loneliness and how that can be as significant of a risk factor for disease as smoking 15 cigarettes per day. And then that there's also this dynamic of the physiology, because I do see that people do a lot of internal, because I also teach meditation. I'm part of a nonprofit meditation community, and I see people who do a lot of internal work, and yet it doesn't correct the B12 deficiency that they're dealing with. And so it's this very complex situation of a mind-body. I see it as one single mind-body process and not these separate compartments that are so often spoken about. And we can't ignore also the interrelational dynamics and the environmental dynamics as well. So all of those put together started me to paint a picture for having some internal trauma from childhood around what happened with my father, around a couple of other things that happened in my childhood that were, I had a wonderful childhood, but there were a couple things that happened that were not good. And those things contributed, together with some probably environmental exposures. I know mold later in life, I'm guessing some other things earlier in life, contributed, together with the internal mental emotional space, and all of that together creates this picture that allows for what we call a disease process to set in. And often it is limited to, oh, it's this bacteria called Borrelia burgdorferi that we also call Lyme disease. But we know that the number one thing that kills people who have Lyme is actually suicide. That there's so much, and it's kind of sad, but there's so much interplay between the mind, the body, and the environment that there's often a constellation of things that are occurring, and unraveling that constellation takes a lot of time. So I did mostly mention in my story those external parts of the H. pylori and the parietal cell antibodies and the infections. But yes, there's absolutely also an environmental component, a mental emotional component, a trauma component, a loneliness and a relational component, all playing a role.
Yeah, and I think that's the thing I was trying to dig out of you. And it's important for the listeners to understand, right, that it's neat to write a blog post that EBV is the cause of autoimmune thyroid condition, right? And then everybody assumes they have EBV, and that's the issue. Or that everybody who's exposed to mold is going to have mold toxicity, right?
Yeah.
And yet two people in the same home, one has problems with it, one does not, right?
Yeah.
Or that Lyme causes illness in everybody, when one person who spends all their time in the woods has no issues, even though they've had Lyme exposure, and has probably more exposure to ticks than the person who lives in the 30-story high-rise in New York, who never goes outside and has no pets. So there's another component to that. And I think this sexy one thing idea is neat for a blog post, but it's not really reality. And for me, when I'm talking to people about how did we get to the point where they're actually feel disease and they're looking for help and intervention, this has been a process. It's not just the thing. You didn't develop hypothyroidism when you got diagnosed. You didn't develop a GI problem when you found you had H. pylori. You didn't develop a GI problem when you found out you had anti-parietal cell antibodies. Those are the results of dysregulation, right? Whether they're adaptive changes or dysregulation, that's the point we can discuss and debate. And it's probably a combination of adaptability, then dysregulation, then dysfunction, then disease. But it's important. And like in your story, you said, hey, my dad passed. I then started really struggling with fatigue. And so is this fatigue issue the thing, or was the passing of your dad an added stressor to the process that then pushed you into that kind of danger physiology that then led to this adaptive change in physiology of adrenal physiology? And hey, I'm in danger. I feel stressed. Now I'm depleting my serotonin. Now I feel depressed. I can't sleep well. I'm driving that tryptophan to make more fight or flight hormones or antimicrobial hormones, and that's making me more anxious as well. So I always talk to clients, and I'm sure you do as well, it's more about the load than it is the thing. And we often look for the thing and assume that that was the thing, when really that was the last little piece that pushed you into danger response. And then the problem becomes is you think it was quick change into the danger response, but you were already at just right at threshold already.
Yeah.
And we think that if I take away the gluten, right, then everything will get better. But really all that does is just drop you just maybe below threshold, and then one more stressor and you're back into the same operating mode.
Yeah.
So I think your story and kind of telling that and saying, hey, I started having these issues was you were probably close to threshold already based on early experiences, environmental factors, right? Traumas, just the stress load, and then the passing of a parent, especially when there's a good relationship, can be devastating. And if that's enough to push you into a danger mode, now you're either in, we talk about fight or flight, but there's another phase in between, which is freeze, right? Which is, I'm just going to create the shell and try to adapt. And I think that's almost the worst place to be, because you're not running, you're not fighting, and you're just taking it. You're taking the beating and adapting instead of your physiology trying to work its way out of the situation. So I appreciate you sharing that.
Yeah, you make a great point there. And I love this concept of allostatic load, which is kind of what you're pointing to, is that we can handle a certain amount of stress and physiologic dysregulation without symptom expression. And the body's so resilient, and it takes a lot for the body to go into a disease process that's significant. And oftentimes because I do work so much with Lyme and mold, I'll see that probably in my case history with a person, they probably got mold or they probably got Lyme when they were very, very young, is my guess. And then they didn't have any symptom picture until much, much later, when a big stress happened or a mold exposure happened or something else happened that pushed the immune system over the edge, that led that infection to then start to express and become an issue. Many people walk around with chronic infections for their whole lives and never know it. And so there is absolutely this resilience. And for some people, the entry point, it really is, I've seen it be much more powerful of an entry point to use antimicrobials to get the infection down. But for other people, the entry point is much more powerful on doing brain retraining and looking at the limbic system and looking at the fear response and working on a retraining of that response and bringing that level down. And for some people, the entry point really that works the best is environment and getting them out of the home that they're living in. And so it is a constellation, and we're always I'm always looking for where's the entry point and where are the leverage points for an individual, that it's not so simple as one root cause. And yet there are some aspects that, who knows why, it's a combination of a person's belief system and their history and everything that's happened, that there is often an entry point that can start the process. But if a person thinks that that's it and it ends the process, I see recurrence all the time. So the entry point might be changing the environment, but if we don't see them also do some brain retraining, also do some work internally, often it'll come back later, which is why in our practice we integrate meditation and brain retraining and breath work and cold exposure and things that are really working on a different level than just doing herbs and vitamins and minerals and medications and things along those lines.
Yeah, I mean, I talk about that all the time on the podcast. Kelly and I talk about that in our book when it comes out. It's the things that we need to do to help people are often not sexy, but they're typically free. Diet, lifestyle, breathing, sleep. Those are often the low-hanging fruit things that people kind of bypass. You you jump over the dollar bill to pick up the penny, and instead, hey, why not just do the things that are easily accessible to you, that don't cost much to address. And if you struggle with those, then you seek help, but don't not do those first, because those are, I would say, if you're searching out a good functional medicine practitioner and they're not talking to you about those things, you probably need to consider a different functional medicine practitioner, because they may not be doing true functional medicine. So I do want to ask a couple questions, because I talk about this concept of homeostasis, homeostatic regulation versus allostatic regulation all the time. We make this assumption that we operate, our cellular physiology operates the same in an allostatic state as it does in a homeostatic state. And especially when it comes to immune system regulation, when it comes to thyroid physiology, it comes to everything, the physiology runs differently. This is my opinion, okay? And based on everything I've done, and I'll let you wade in on this a second, but it runs differently. The problem is we treat people, especially in an allopathic model, and to some degree in a functional medicine model, we see this especially with thyroid physiology, as if everybody's in a homeostatic state. So like you go to your medical doctor, they say, hey, we're just going to give you T4. As long as we put enough T4 in it, your cells are going to convert it. We're totally ignoring the fact that what's happening at the cell level. Cells and tissues have the ability to self-regulate. It's the beauty of the physiology. So what I'd like you to do is maybe give a short definition of homeostasis versus allostasis. What does that mean to the listener? And do you agree with the concept? Do you think that we operate differently in those two modes?
Yeah, so homeostasis is this regulatory mechanism by which the body keeps itself in balance, and it's wonderful. It means that if you're too hot, you sweat and it cools you down. If your body temperature is getting too low, you might shake and that might help warm you up. There's many mechanisms that will change your blood flow and your heart rate and all of these different aspects of physiology that you don't have to think about. They're just automatically adjusting all the time to keep a certain level of balance and function. Then when there becomes a significant allostatic load and when there becomes so many stressors, let's say there are some traumas and an infection and some environmental exposure to toxin and several other aspects of relational difficulties and stress in a person's life, these we know, for example, that the hypothalamic pituitary adrenal axis, so the brain, the glands in the brain that communicate to the adrenals how much cortisol, which is a stress hormone, to produce, can be overridden. That homeostatic balance of keeping a good level of a balanced level of cortisol that'll wake you up in the morning but not have you be too stressed, can get overridden by external stress that's enough, can override that signal, and you can start to develop a resistance to cortisol. So then the levels of cortisol can become chronically, there are studies on chronic stress where it shows that it can reset the baseline. So the baseline level of cortisol that would be a healthy response can get reset to be either excessive or deficient all the time as a baseline, where the body is going back there, going back there, going back there, as a new baseline that may be served during that period of chronic stress. But when that chronic stress ends and you don't have that stress input, now the levels of cortisol that were needed to deal with that chronic stress are no longer needed, but the body has set a new balance, has set a new, almost like the thermostat got set a couple degrees higher during the winter, but then during the summer it didn't reset. It's that sense of the body's ability to deal with stress is very good, but then it can push the body into a new kind of a dysregulated or dysfunctional balance where the immune system can be set to being attacking certain tissue, for example, in an autoimmune situation, and continuing to attack that tissue. So that would be this reset of an unhealthful balance, but the body keeps going back to that unhealthful balance. after a certain level of allostatic load.
Yeah. So let me which is all that's good, but I want to kind of simplify it for the listener, because we talk because we geek out on that stuff, but somebody's going, but I still don't understand what it is. So homeostatic is like a non-stressed regulating mode of physiology. You make enough energy to do everything your body needs to do, and it can kind of do exactly what Dr. Nichols was saying was, hey, if you're cold, you get warm. I mean, the body has enough energy to constantly shift and adapt and do what it needs to do. Allostasis is a situation where you've got more stress on the system and you don't have enough energy to support all those individual stressors. So the body has to kind of change the physiology. It's going to turn off energy to the less important processes in the moment and shift energy to the more important processes in the moment. The other part that goes with that is that there may be certain systems and where energy, and especially when it comes to cell danger and cell stress, where we want to actively turn down the energy on purpose to prevent an organism or a threat from thriving in an environment. So we want to create a low energy state. And we'll talk more about that in thyroid physiology as we get there. But for the listener, when you've got bills to pay and you've got an injury and you've got the thyroid issues and you got blood sugar issues and you got a crappy diet, you're not sleeping well, and you got all those things. So it's essentially like you blew a fuse. And now you've got that there's powers out in your house. You got to get the gas generator and you pump, you turn that thing on, put it in the garage. You can't run your whole house on that little generator. And so now you have to pick and choose, what am I going to run and run well? Well, the freezer becomes the immediate thing. The refrigerator becomes the immediate thing. You want to go get a hot shower. You're not going to do that because it's going to blow the generator. That's how our bodies kind of operate when we're in excessive stress mode. I can't put time and attention to certain things because I got to put time and attention and energy to these more important things. And when we see that many times, the things that get turned down or tuned down are things like gut function, hormone production and hormone regulation, neurotransmitters that make us feel calm and peaceful. And you would wonder, like, why would the body shut those things off? Well, if your bodies or your cells are perceiving danger, they need to be in defensive mode. If you are being chased by the proverbial tiger, you're not going to stop and have sex probably. So sex hormones in that time frame where you're in excessive stress, you don't need to put energy towards sex hormones because your body is really focused on defense. You don't need good stomach acid, which we're going to talk about, in bile production and pancreatic enzyme output if you're being chased by the proverbial tiger, because I'm not stopping for a meal, right? You're not going to stop for a meal if you're being chased by the tiger because you will become the meal, right? You don't need to get deep, restful sleep if you're in danger mode, if the tiger's chasing you. What you need to be is any little noise, right? And you're alert and you're like, oh my gosh. So you don't get into that deep sleep state. And to some degree, we think that's broken physiology. And at least from my standpoint, I want people to at least understand, at least in the beginning, it's adaptive physiology, not broken. But if you leave somebody in an adaptive state, in an allostatic regulating mode for an extended period of time, and we don't give attention to the GI tract, the enzymes, the hormones, the immune support it needs, and it starts to become dysregulated, then it becomes dysfunctional, and then eventually it becomes diseased. We see the disease and think that's when the process started, but in reality, you've probably been in an allostatic mode of regulation for a couple years or decades, right? Would you agree with some of those comments?
I would, yeah. And I'd extend it to say, when someone's gone through a very intense or chronic period of a high allostatic load or lots of stress or lots of trauma, often the body, it is adaptive in that time to deal with that situation. And then after that time passes, sometimes the body stays in that altered physiology, that new baseline. And studies on chronic stress show this, where with cortisol, the stress hormone, it changes the baseline even after the stress goes away, if it was there for long enough. So if if there's a time or situation where you went through a really difficult period, often you come out on the other end of that period and the body has reset adaptively to deal with that period, but it doesn't go back to where you were before without some work. And that you can definitely do that work and get back, but we know that there's this new baseline that can be set that's unfortunately, like you said, leads to certain energy not going to certain areas enough and too much energy going to other areas for people no longer feel balanced and feel well.
Yeah, and I think the key is that it happens with multiple systems. It can happen with the immune system itself, where the immune system actually kind of gets stuck in a mode because it's been plasticized into that. It's been operating the same way. And I guess if we had to explain it to the listener, if I taught you the alphabet, A, B, C, D, E, F, G, and then I let you do it inappropriately for a couple years, A, B, C, G, F, Y, Z, and you just repeated that over and over. That's the way you repeated it. And I encouraged it. We did all that. And then I came back 5 years later and said, hey, by the way, you're doing it wrong. We got to go back to the other way. You'd have a hard time probably adapting because that's what you've gotten used to. And that's kind of how our physiology is. Once it can get stuck in a mode. And I kind of explain it to patients like, if you push down on the gas pedal, you expect the gas to go. But when you take your foot off the gas pedal, sometimes the gas pedal could get stuck. And all you need to do is encourage it to come back. Sometimes the gas pedal is in that position because there's something still driving it. And that's kind of what we're going to kind of get into here and kind of what we talk about when we talk about mold and Lyme and autoimmune issues. I don't always look at autoimmune issues, at least in the beginning, as a immune system out of control. I look at it sometimes more of the adaptive changes that occur when there's cell tissue and problems. But if that system becomes stuck in an adaptive mode, then yes, the initial trigger, the things that drove it may go away.
Yeah.
And that becomes the problem. Maybe Lyme triggered an issue and that initiated it. Maybe that Lyme goes away. You keep trying to treat it because you think it's still there, but it's really what's there is the immune system just needs to be helped to be shifted back. And that could be emotional trauma. The person who created the emotional trauma or the physical trauma as a youth is gone.
Yeah.
But the body is still operating as if they are there because of what goes on maybe between the 6 inches of their ears, or it never shifted back to that mode, right?
Yeah. I actually think we have a really good specific example of that with parietal cell antibodies. So
let's talk about what are parietal cells and what are parietal cell antibodies.
So parietal cells are cells in the stomach. These cells make stomach acid, and they make something called intrinsic factor. Stomach acid is really important for breaking down, especially proteins, into smaller amino acid parts to make proteins absorbable. Now, this is really important when it comes to other autoimmune issues as well, because often the reason why the immune system forms an autoimmune situation has to do with protein structures that make their way into the bloodstream that are foreign, that the immune system attacks, and they happen to look like thyroid tissue or look like other tissue in the body. So when stomach acid has an issue, then proteins aren't broken down as well into their amino acid parts, and these bigger proteins may not digest as well. And if there's leaky gut or intestinal permeability, these bigger proteins may get into the bloodstream and may trigger what's called molecular mimicry or cross-reactivity, where the immune system thinks, oh, that milk protein looks a lot like that beta cell in the pancreas, and then diabetes type 1 or type 3 later on that could form as a result of that confusion by the immune system. Now, parietal cells themselves also produce intrinsic factor. An intrinsic factor is something that's needed to absorb vitamin B12. Vitamin B12 is so important for energy and nervous system function and brain function. So vitamin B12 is one that is, if it's deficient, then we see fatigue, we see nervous system problems, brain problems, and we see nerve problems like neuropathies or tingling in the fingers, tingling in the toes. And what's very interesting is that with parietal cells making intrinsic factor and intrinsic factor absorbing and properly utilizing that vitamin B12, that essentially is part of how any vitamin B12, be it from the diet or even oral supplemental B12, is absorbed. So when intrinsic factor has a problem, when parietal cells are having a problem or intrinsic factor is having a problem, then the B12, even if taking extra of it to try to deal with a deficiency, may not absorb and metabolize and have as strong of an effect in the body as one might think. And so parietal cells are very important for the ability to properly digest food, especially protein, to absorb minerals, because a stomach acid also helps with mineral absorption, and you can see mineral deficiencies from low stomach acid. You can also see acid reflux and heartburn from low stomach acid, as odd as that sounds in the beginning to some people. I think a lot of people who have been in the functional space might know that, but if someone's new, that might sound odd. But when there's low stomach acid, the sphincter can have a problem, the lower esophageal sphincter, and there can be spasming, and bits of stomach acid can go into the esophagus and cause a feeling of heartburn or regurgitation or acid regurgitation. So these are all things that can happen when parietal cells have a problem.
So, but let's go back, because the average person, all that's good chemistry, but that's maybe a lot of muckety muck for the average person. They're going, okay, but why do I have low stomach acid to begin with? Okay, because you're saying, hey, if I have low stomach acid, that can set the stage for poor protein breakdown. The poor protein breakdown, now you've got this potential for the immune system to inappropriately attack parietal cells versus these proteins. What's driving the low stomach acid to begin with? Because we've got about 50% of the US population on antacids. So, and nobody, yeah, from your medical perspective, you may hear that you have too much stomach acid. And I think we have to clarify that, because sometimes we say it's too much stomach acid. A medical physician may say we may say it's too little stomach acid. A medical physician may say it's too much stomach acid. And I think we're stuck in the gray zone. The issue is, it's too little stomach acid in the stomach, but that leads to too much stomach acid or bile acids damaging the esophagus, which does not have the ability to take an acidic environment. The esophagus is usually in a pH of like 7.0. The stomach acid content can get down to a pH of 1 to 2, which would eat through your floor, right? So even if you had stomach acid coming up into the esophagus and it was a low acid state and it's, say, a pH of 4, it could still create some damage. So what's driving, from your perspective, what's driving this low stomach acid state to begin with?
Yeah, so parietal cells make stomach acid. So one driver of low stomach acid is antibodies to parietal cells. If the immune system attacks parietal cells and there are fewer of those cells, there will be less stomach acid production, because those cells are what make stomach acid. So that's one cause of low stomach acid, would be parietal cell antibodies. And then we have to look, what's the cause of parietal cell antibodies? So we keep going upstream. But We know that H. pylori, as well as a bacteria that can live in the stomach, can produce alkaline secretions, which alkaline would offset that stomach acid in order to survive in that acidic environment of the stomach. It used to be thought no bacteria could survive in the stomach, and it took an Australian scientist who got laughed off the stage to consume a petri dish full of H. pylori, induce gastritis on himself, and then take antibiotics to convince the medical community that a bacteria could even live there. And he ended up winning the Nobel Prize for that later. But the bacteria H. pylori can cause also changes in the stomach, inflammation, gastritis, ulcers, and low stomach acid. So that's another cause of low stomach acid. Of course, poor diet can be a cause of low stomach acid, and then other environmental things can contribute to changes in stomach acid. Small intestine bacterial overgrowth can be caused in part by low stomach acid, but might also relate to why a person develops low stomach acid. So there are several things that can cause low stomach acid. Parietal cell antibodies are one that could cause low stomach acid.
Yeah, so it could. So if the parietal cell antibodies came first, then we would say, hey, that could contribute. But if we're looking at what might drive a low stomach acid state, I think one of the things, especially because this is the Thyroid Answers podcast, we'd have to say that one of the things that's critical to stomach acid production is T3 at the stomach. You have to have optimal levels of T3. You need histamine. You need a bunch of different things to make it. And if you don't have appropriate levels of T3, what I call tissue and what the literature calls tissue hypothyroidism, that may be the underlying reason potentially why you might not make sufficient stomach acid. So then, yeah, we'd ask the next question, well, why would you not have enough T3 at the stomach? And if we go back to the same things we were talking about early on, which kind of set the stage for this conversation, if you are a person who's got in an excessively stressed state, if you're in allostasis and if you're in fight or flight mode and you don't even realize because that's become your norm, is your body going to take the limited amount of energy it has and make more stomach acid, or is it going to use that energy to make more fight or flight, inflammatory, immune defending proteins and hormones and enzymes? And the likelihood is it's probably the latter, right? What do we see? We see people who typically are in higher states of stress are the people that develop reflux and stomach ulcers and all those issues. So there's a big role to play there. You talked about meditation before. Like if you're working on meditation, could that help your stomach acid? Absolutely. If it brings you out of a sympathetic state and into what we call a parasympathetic state, now you have a greater opportunity for your body to say, hey, we're good. Let's work on making some stuff to digest this stuff. So good part there. We talked about stomach acid. We talked about parietal cells kind of help generate that stomach acid. We know that once there's immune issues, if there's antibodies, that's going to further cause even more. If you have this stuff called H. pylori, which is a bacteria that comes where's somebody going to get H. pylori? That's what people want to know, is where are they getting this H. pylori from? Does it fall like fairy dust from the sky? Where are they getting it from?
Yeah, so H. pylori is so in a very healthy stomach with good stomach acid, H. pylori won't survive. That's part of why it has to produce alkaline secretions to even survive. So there's a lot of people get exposed to H. pylori, especially children, and many don't contract it because of having a healthful, robust system. Again, it's the environment that allows for it to be contracted, but it can come through food, it can come through saliva, so it can come through sharing of saliva in the various ways that the kids share saliva all the time, and then adults more, it's kissing and things like that can involve saliva sharing. Animals can carry it, so a dog could carry H. pylori. But again, if the environment is ripe, it won't contract. But it is estimated that a huge percent of the world population has H. pylori, and it increases as people get older as to the percent of people who have H. pylori. And it may be protective in some people and pathogenic in others. And there's research showing that if people got it probably when they were very young and the immune system was evolving together with it, it may actually be protective. And that happens a lot in developing countries where there's less cleanliness. It's contracted at a young age and it may be protective in those cases. When it's contracted at an older age, we usually find that it's a little more pathogenic in most cases. So that's where it can come all sorts of places.
And sometimes pathogenic, sometimes just problematic, right? Because when we think about the pathogenic portion of that, we think about stomach driving stomach ulcers, we think about it driving stomach cancers. And for the person who's listening, well, I have H. pylori, am I going to get stomach ulcers or cancer? No, it's really based on the type of H. pylori, and there's what they call virulence factors that make these things more potentially more damaging to the tissue. And I do want to touch on that because we talk about, somebody might be thinking, well, how is a bacteria that's in my stomach that's not supposed to be there potentially helpful? What we see in countries where there's more, not the same level of uber kind of cleanliness, right? We see in some countries where they have a higher level of GI parasites, worms, right? That those countries typically have less autoimmunity. And in countries where we don't have the parasites and the helminths and the worms and the stuff that we all consider gross, we have higher levels of autoimmunity. And even in the autistic community, they're using sterile helminths to try and help, and they're seeing benefits from putting these worms into children. I know that somebody's sitting there going, what are you talking about? But they're putting sterile worms. They're not going to multiply or just should not be multiplying. But what are they doing? Why would there be any tie into that? I'll let you kind of talk about it because as I'm seeing you nodding, you have some familiarity with that.
Yeah.
But how could an organism be helpful?
Yeah. There's the old friends hypothesis, which is essentially that humans co-evolved with certain kinds of hookworms or helminths that were always for just about 100% of the population living together with humans, and they're considered today. A lot of people talk about them as parasites, but parasites don't have a bidirectional relationship. Parasites only take and they don't give. But we know, and we've seen there's pretty good evidence that there's almost like a check and balance for the immune system when dealing with very low levels of they're what are called hormetic stresses. And we know, for example, that if you exercise, that's stressful to your muscle tissue, but it grows stronger after. That's the most obvious example. But a lot of people, they don't know that a lot of the antioxidants that you talk about, like green tea, for example, is a mild pro-oxidant, really, that stimulates antioxidant production in the mitochondria. It's these mild stressors that are producing a robustness or a resilience of an ability to deal with these mild stressors. And helminths fall into that category of it's a mild inflammatory continuous response that, in a way, you can think about it, it's overly simplistic, but you can think about it as it distracts the immune system from being so overactive about little things that don't matter. Or, it's sort of like the immune system, if it has nothing to do, might go pick on like little things, and that might lead to it attacking your own tissue and cells. That's grossly oversimplistic, but it's a good way to think about it, that the immune system has evolved with these low-level stressors, and dealing with these stressors, it's become very strong to deal with these stressors, and then these stressors go away, and then it's looking for a fight almost. There's no check and balance, and there's not the hormetic stress present continuously. So helminth therapy is a therapy that it's not used commonly in the United States, but I have patients who've done it. I've even experimented myself a bit with helminth therapy because it is very interesting, especially when the immune system dysregulation is a part of the clinical picture.
Yeah, and I'll add to that, when for the listener, when you're thinking about it, like 70-80% of the immune system surrounds the GI tract. So the GI tract is really the outside of the body. And so we dump a bunch of food in there. There's a bunch of organisms living in there, and the immune system surrounding that area. And so if you've got compromised gut physiology and you've got inappropriately digested food, it's the inappropriately digested food that can create some irritation, it can create inflammation, that can upregulate the immune system. And if you have these organisms, whether they're sterile organisms they put in for a therapy, or if you're naturally picking these up in your environment, and by all means, we're not saying go out and get yourself a roundworm or a tapeworm or a hookworm, but the issue is, if those things are in you, yes, could they create a potential problem? They could, but they also are in the GI tract cleaning up all of that debris. They're kind of like keeping that area more clean, more sterile. They're consuming it. Now, they may be competing with us for some of that nutrition and for the organisms, but there's less of that debris material that could incite an immune and inflammatory response. And when you have an immune and inflammatory response in the gut, you have an immune inflammatory response in the brain, and you often have an immune and inflammatory response systemically in other tissues. And from an autistic spectrum, if you have less GI inflammation, because those helminths are keeping that protein debris broken down, keeping that GI tract essentially a little bit less inflammatory, then you get less brain-based inflammation, and they're seeing improvements in these kids. So
yeah, and the helminths that are used are ones that don't, they are alive, but they don't reproduce. In the way they reproduce is they lay ova, and those ova go out with the stool. So they don't have a full internal cycle, so they don't grow inside of the person. They go out with the stool. And some of them even go to the lungs, which is weird for people to think about, but they're able to regulate some of the immunity and physiology in the lungs as well. So, but you get too many of the one that can be very healthful and helpful. You get too many, and you'll induce an iron deficiency because they're consuming iron. So you don't want to mess around with it unless you know really what you're doing.
yeah, we're definitely not saying going out there. We're just talking about, you could be in balance, and you have trillions of bacteria that are in you.
Yeah.
And they need to be in a certain balance. And then it's a symbiotic relationship with us and our gut flora, or it's a problematic relationship with us and our gut flora and our gut organisms. But let's get back on the parietal cell antibodies. So we have something happens to stomach acid, something reduces it, right? Now we have this anti-parietal cell antibodies. If somebody has anti-parietal cell antibodies, they may or may not have problems with intrinsic factor antibodies. Okay, so we can talk about that in a sec. But what are the signs and symptoms that might lead somebody to think that they have a problem with their parietal cell production, or that they might have anti-parietal cell antibodies? What might lead somebody to consider that as a problem and potentially go get that checked?
So we know that 20 to 40% of people in research who have thyroid autoimmunity or hypothyroidism, low thyroid hormone, have parietal cell antibodies. So you're one in 5 to 2 in 5, 20 to 40% of people who have thyroid issues have parietal cell antibodies. That's how I first tested myself, because I had a thyroid issue, and I was looking at research that showed things that are a little more likely to happen for people with thyroid issues. So there are also increased incidence of parietal cell antibodies in other autoimmune conditions. And there are several autoimmune conditions that have been researched. So the current thinking is, with any autoimmune condition, there may be an increased likelihood for parietal cell antibodies. If there's pernicious anemia, then there's almost certainly parietal cell antibodies. So if there are issues with low B12, or if people have been diagnosed with not an iron deficiency anemia, but the B12 deficiency kind of anemia, then almost certainly there are parietal cell antibodies as well in that case. If people have low stomach acid for any reason, it's probably worth testing for parietal cell antibodies to see if that might be part of why the stomach acid is low, because we know that the parietal cells make stomach acid, so we see that relationship. And if someone is responding well to taking extra betaine HCl, or they know that they have acid reflux, or if they know they have or have had H. pylori, that's also an increased chance for developing parietal cell antibodies. So thyroid issues, any autoimmune condition, H. pylori, pernicious anemia, or issues with B12, issues with stomach acid would all be reasons to take a look at parietal cell antibodies.
Okay. But why do you think it's common that nobody's testing for parietal cell antibodies? Because it's rare that I see anybody that's tested for anti-parietal cell antibodies. Why do you think physicians aren't testing for it?
Yeah, and we do a talk to practitioners about parietal cell antibodies, and people are amazed at the research that's there. And it's once they hear that talk, they start testing for them more. But I think that parietal cell antibodies are something that are commonly tested with pernicious anemia, and that's about it. And I think that practitioners it's an up and coming thing. I hope, and part of my message, I'd like practitioners to be more aware of and test for parietal cell antibodies, because I have seen it be an important player. It was certainly an important player for me in my own thyroid issue, even though I don't think that parietal cell antibodies cause thyroid issues by any means. I think that they go together with thyroid issues, and then they cause other digestive and B12 absorption problems. And B12 is so related to energy, and fatigue is such a common symptom that goes with low thyroid, that even when thyroid is repleted, and so a lot of people, they go and they have low thyroid, and the approach is replace thyroid. And they have low B12, and the approach is replace B12. They have low stomach acid, and the approach is replace stomach acid. Unfortunately, a lot of people are looking at the reasons why. And so when you look at the reasons why low B12 and you test for parietal cell antibodies, then you can actually help the body to be able to, again, start to absorb, metabolize, and utilize vitamin B12. And for me, and interestingly, the research on parietal cell antibody treatment is that you can reliably lower those antibodies with vitamin B12 injection, but it won't work with oral B12. It won't work with sublingual B12. It won't work just eating more foods that have B12. It has to be injectable B12. And this is one of those cycles that we were talking about, where people can get out of balance and then the body stays out of balance. When parietal cell antibodies form and the immune system attacks parietal cells, which make intrinsic factor, and there's less ability to absorb vitamin B12 because of intrinsic factor, and then there's less ability for the body to be able to deal with those antibodies and reduce them. So B12 injection will reduce the antibodies, but you can't get enough B12 orally. And I've tried super high doses of B12. I've tried sublingual B12. I've tried topical B12. I've tried just about every form of B12 that isn't injection. And I've not been able to lower parietal cell antibodies reliably with those other forms. Of course, we're working on other root causes, and that can help. But injectable B12 reliably lowers antibodies. And I thought I had ruled out B12 as a contributor to my symptoms. My diet had plenty of B12. I took B12 in supplemental form. I got my blood levels looking really high for B12. But once I discovered parietal cell antibodies, and I saw that the researched treatment was injectable and not oral B12, and I started to do B12 injections, It was dramatic for me in terms of the energy shift. And I didn't realize, and I thought I had ruled out a deficiency of B12 playing a role in my chronic fatigue. But once I started injecting, it changed in a way for me that no other form of B12 ever did. And I saw the parietal cell antibodies normalize over time. It took a while, but they eventually normalized with B12 injection, plus all the other things that I was doing.
Okay. So I got a bunch of questions after you said all that stuff. So people, so I guess the first place to go is explain to people why the injection would reduce the parietal cell antibodies.
That's unknown as to why the injection reduces parietal cell antibodies, but it's very clearly researched that it does. So when we look at a research trial where they inject versus give oral B12, the oral B12, when they recheck antibodies, the antibodies stay the same or they go up over time. In the group that receives the injections, the antibodies go down. And there's no known mechanism as to exactly why B12 injection reduces parietal cell antibodies, unfortunately.
And that's an issue with a lot of things. We don't know a lot of stuff. We make assumptions. Yeah. So for the listener, I'll make a couple assumptions, right? One of those is that if you are deficient in B12, there's likely a signaling mechanism that says to the stomach, like, hey, we need more B12, increase that intrinsic factor, start pulling that stuff out of your food. There's also probably a signaling mechanism that if you're eating things that are rich in B12, that maybe there's a trigger that it activates there. I would think that the more likely scenario is when there's a deficiency in the body, there's an intelligence there that says, hey, we got to drive more absorption of this stuff in, and there's signaling mechanisms. But we don't, you're right, we don't know for sure. But the problem is you're not going to deplete all the foods of B12 out of your diet, right? So I don't want people to think, hey, the only solution here is to get B12 shots and don't eat anything or take anything with B12. There's got to be some other things here. And I'll hit you with some more questions on those here in a second.
Yeah, and just to clarify quickly, it's not that oral made it any worse. So oral B12 and foods with B12 were fine. They just didn't produce the desired therapeutic result of lowering the antibodies. So there's no need or reason to avoid B12 in diet or supplementation with parietal cell antibodies. It's just that increasing B12 very high in supplements or in diet didn't produce the therapeutic result of lowering the antibodies, but it helps to some degree. It just doesn't reduce the antibodies. So there's no need to avoid any of those things.
Okay. Because I thought you said it either stayed the same or went up. And so that would then lead, if the antibodies are going up, then that would lead somebody who's going, well, if I'm eating food and taking supplements that have B12 and it's making my antibodies get worse, that's not good, right?
Yeah, thanks for mentioning that, because the antibodies do stay the same or go up with oral, but they go up without any oral B12 even faster probably. So it's not that the eating of the B12 or the taking of B12 supplements are what's making it go up. It's that the whatever the internal process of parietal cell antibodies over time usually goes up unless there's intervention. And so basically oral B12 just doesn't stop the process, but it doesn't put fuel on the fire and make it any worse.
Okay, so that's an important point to say. And that would kind of make more sense then for, hey, if I do really have good levels of B12 because I'm getting an injection directly into the body proper, and I'm taking the gut away from it, and I'm getting signaling to say, hey, I'm good with B12, then that would be a reason. If you still are relying on the gut to pull it in, and there's multiple places along the GI tract where that B12 is not either being produced or absorbed, you're still going to have a problem, right? Is that fair to say? And it's important for people to know that, yeah, the intrinsic factor is critical for B12 absorption. You got bacteria that plays a role in there. And then you've got other issues that could play a role. If you don't have appropriate stomach acid, you don't get appropriate bicarbonates production. You don't get appropriate pancreatic enzyme output. It can impact bile flow. So there's a lot of reasons why you need an acidic chyme to impact absorption of B12 and other things in the duodenum and further down into the GI tract. So let me ask you the next question, because there's two terms that we hear about. One is anti-parietal cell antibodies and one is intrinsic factor antibodies. So can you tell people what's the difference between the two of those things?
Yeah. So anti-parietal cell antibodies, the immune system is attacking those parietal cells directly in the stomach, and the parietal cells make intrinsic factor. So you'll usually see a deficiency of intrinsic factor when there are parietal cell antibodies, because the immune system's attacking and reducing the number of parietal cells. So there are fewer parietal cells to make intrinsic factor. Intrinsic factor antibodies are where the immune system directly attacks the intrinsic factor. Someone may or may not have both of those. Some people who have parietal cell antibodies also have intrinsic factor antibodies. Some could just have intrinsic factor antibodies where the parietal cells are normal, in which case the stomach acid production might be normal, but the body would be attacking the intrinsic factor, which absorbs vitamin B12. And so the B12 would be a problem in that case. And so it could be one or both of those that are an issue. If it's parietal cell antibodies, that can cause issues both with stomach acid and B12. Intrinsic factor antibodies cause problems specifically with B12. And both could be going on at the same time in some cases.
So do you know, because we talk about, in thyroid physiology, everybody talks about the antibodies eating away the thyroid gland and causing all the damage to the gland. And the literature shows that that's just not the case. So the immune infiltration causes the damage. Thyroglobulin antibodies don't cause any damage to the thyroid gland. And it's not the TPO antibodies, which get all the blame, maybe create a very small amount of actual damage to the gland. There aren't little Pac-Man eating up the gland. The most recent paper I saw is maybe less than 5% of the damage to the gland is caused by the TPO antibodies. So then the question becomes, is what we're seeing with anti-parietal cell antibodies or anti-intrinsic factor antibodies, is it the antibody causing the damage, or is something causing the damage and the antibodies are there as the cleanup crew and really maybe not creating the damage we think it is, like in the case of thyroid physiology? What do you know about that?
Yeah, and there's a lot of confusion around causation versus correlation. So we can correlate high antibodies and damage to tissue. That doesn't mean that the antibodies are what is causing the damage to tissue. And this is the same with hormone levels. We can correlate high thyroid hormone, such as in Graves' disease, with things like bone damage and atrial fibrillation and heart problems. But when you intervene with someone who doesn't have Graves', who doesn't have that autoimmune process, and psychiatrists sometimes give these supraphysiologic, really high doses, you don't see any of the bone damage. You don't see any of the heart problems that you see in the people who have the Graves' autoimmune process going on. There's a lot of confusion between when you see correlative studies, and there's a lot of assumption that it's what you're seeing correlated causing it, but it's not necessarily the case. And in fact, often it's not the case. And so in what's causing the damage, because in thyroid physiology, sometimes we see in hypothyroidism, no antibodies. We test all the antibodies, but then on ultrasound, there's damage to the gland. So
exactly. And we know that often it starts as a thyroiditis.
Yeah.
And that's a Th1 potentially dominant initial part. People talk about it as a Th1 or as a Th2. It's actually both. Many times it starts as a Th1 dominant disorder, and it takes time for that to shift into a Th2 disorder where you have lots of antibodies. And now we go, oh, you just have thyroiditis. And then 5 years later, now you have Hashimoto's. No, listen, you had thyroiditis the whole time. The only difference is you weren't making antibodies at the time. But whether it's Hashimoto's, thyroiditis, or thyroiditis, it probably doesn't matter. It's a thyroiditis. It's an inflammation of the gland. That to me is probably one of the biggest things that people are like, well, I have thyroiditis, but it's not Hashimoto's. I don't have an autoimmune condition. You do. You have your immune system is damaging your thyroid gland. Is it broken or adaptive? That's an argument. But you still have an immune-based disorder if there's thyroiditis, right?
Yep.
So let's talk. We got the anti-parietal cell antibodies. We got the intrinsic factor antibodies. Now we've got people, and you're talking about the big issue here is it, especially in your situation, it caused B12 deficiency, right? So this is a pet peeve of mine. Explain to people what's the best way to evaluate B12? Is it serum B12 or is it more than that?
Yeah, so serum B12 is better than nothing, but it's nowhere close to the best way to evaluate B12 status. The body does a pretty good job of putting nutrients into the blood, and the cells might be getting the short end of the stick in a lot of cases. We see that this is the case with B12. We see this is the case with many different minerals where the blood levels and electrolytes, or the blood levels will look fine, but someone's clearly having cramping and twitching and they have a severe electrolyte imbalance, but you don't see it in the blood because the body prioritizes, let's keep everything in the blood balanced, even if we have to pull out of the cells where the intracellular levels are getting really imbalanced and it's causing problems. So B12, if we see it low in the blood, that's like a late stage B12 deficiency. And it's a really significant level of B12 deficiency. And the lab ranges are insufficient. In Japan, it's at least 400. Here in the United States, they say you can go down to 238 or so. Most labs have 200s as the low end of the range. Certainly anything below 400, there's good evidence to suggest that that's already a late stage B12 deficiency. To find an earlier stage B12 deficiency, because a lot of people with myself, when I had parietal cell antibodies and I was taking oral B12, my blood B12 looked like 1,000, 1,200. It topped the assay, it just said greater than 2,000 sometimes. But it still, I wasn't getting it into the cells as well as I needed to, because the injections were so profound for me. And so we run a lot of methylmalonic acid, which is a urinary marker or a blood marker. It's better in the urine as an earlier sign of B12 deficiency than B12 in the blood. So methylmalonic acid or MMA in the urine will flag elevated sometimes when serum B12 or blood B12 looks normal, and that's a sign of deficiency. So it's an earlier sign of deficiency. Tell
people what that means, because I think it's really important, because everybody gets their B12. I see doctors run B12 all the time. They say it's good. It's the same thing we run into with somebody says, well, your T4 is good in the blood, your T3 is good in the blood, so therefore it's good. No, everything is about what's happening at the tissue level. And serum B12 can be normal, as you're saying, but it may not be normal or sufficient in the cell. So there's two markers really when we're thinking about inside the cell. Maybe homocysteine is a good marker. We could take a look at methylmalonic acid. We could take a look at the CBC and differential to look for patterns or indicators of a B12 issue there. But talk about what methylmalonic acid is, because most people have never heard of what that is, and how does that symbolize a B12 deficiency?
Yeah, so methylmalonic acid is what we refer to as a metabolite or a byproduct of the way that B12 gets utilized in the body. So it's a proxy that helps us to see how well is it being utilized in the body. Now, it's still not the earliest stage of deficiency, so you can still have normal methylmalonic acid and still have a level of B12 deficiency, but it's these metabolites that are byproducts are helpful to determine an earlier stage of deficiency than the blood levels.
So yeah, I'm going to just jump in. I just want to, so for the listener, when you're thinking about B12, B12 is this vitamin, right? It needs to get into the cell, and the cell utilizes, there's often things when we look at the supplements, there's methyl B12 and hydroxy B12 and adeno B12, right? Adenosine B12. And so each of those, the B12 is important, and then the thing it's attached to is also important. And inside the cell, there's methyl B12 often is used to help with methylation reactions. So the B12 goes and does what it needs to do, and the methyl group comes off and does what it needs to do. Inside your cell, you have these things called mitochondria, and these are the engines of the cell. And when you take this methylated B12, what the mitochondria really wants is what we call adenosine B12. So the conversion of this kind of methylated B12 to the adenosine form, which is what the mitochondria needs, if you're not doing that conversion appropriately, then we see this methylmalonic acid show up in the blood or in the urine. And you might say, well, what's the big deal? Well, that adenosine piece, you need that conversion to the adenosine piece for that mitochondria, because the mitochondria's primary focus is generating something called adenosine triphosphate. Adenosine B12, that adenosine molecule comes off and becomes the backbone of your ATP, this energy currency. Really, really important. And for patients who have hypothyroidism, tissue hypothyroidism, which is, to me, is the primary form of hypothyroidism, if you have a low T3 state, you have mitochondria that are less productive, okay? And so if you have less productive, less functional mitochondria, you might not be driving that reaction appropriately. It's odd, your mitochondria may actually become more efficient at utilizing energy, but they can't handle the volume of nutrients coming through because they do less, they lost their leakage, but they could actually become more efficient. But that's a really important piece. If somebody has high methylmalonic acid, what that should tell us is I'm not getting the form of B12 to the mitochondria I need. And because of that, I can't generate ATP appropriately. If I can't generate and use ATP appropriately, I'm going to be tired, fatigued, poor recovery, all those things, right?
Yeah. Thanks for that explanation. And you mentioned homocysteine too. And the reason why homocysteine can elevate in the blood when B12 is low is because homocysteine gets recycled into methionine, and that recycling process utilizes methyl form of B12, methylcobalamin, to donate a methyl group that helps change homocysteine into methionine. And there are other things that can cause homocysteine to elevate. So folate and methylfolate is another. Choline can help recycle homocysteine, and vitamin B6 can help recycle homocysteine. So homocysteine is a little more complex, but B12 deficiency is one of the things that can cause elevated levels where it's not recycling into methionine. It's an inflammatory protein that can build up in the blood, and we see that lab ranges sometimes can go up to 14, 15 for homocysteine, but even at as little as 9, we see increased cardiovascular disease risk that's very significant, and stroke risk and Alzheimer's dementia risk starts to increase with increased homocysteine in the blood. So from a functional perspective, we actually want to get homocysteine back towards that 7 is a great place to see it in the blood for US-based labs.
Yeah, I agree with that. And so for the person, the point that the reason we're digging in on this is because if somebody's testing you for B12 and they just do your blood level of B12 and it's normal or high, they may say you have plenty of B12 in the system. But I always say what we want to do with labs is not read them for high or low, but we need to interpret them based on other lab values. based on your signs and symptoms, based on your diagnosis, based on your supplements, based on your medication. So if you're taking B12 and your B12 in your blood is high, that doesn't mean you don't have a B12 problem in your cells and tissues. So we want to look at what's your homocysteine. Is that regulating well? And Dr. Nichols is correct. It could be caused by a bunch of other things, but it's at least another marker we could look at and go, homocysteine's elevated, but let me look at another potential indication of B12 issue. What's my methylmalonic acid? That's normal. So maybe my elevated homocysteine isn't a B12 issue. Maybe it is a B9 issue, a B6 deficiency, some other issue going on. And then we can look at other factors as well. We could look at our CBC and what we call our red blood cell differential, like our CBC morphology, and we can take a look at what's going on with there. Somebody who's got a B12 deficiency, what's that going to look like on their CBC panel or the red blood cell morphology?
Yeah, so usually we're not going to see any abnormality, but if we do see MCV elevation, then that's something we absolutely want to, that could be a even very late stage. Usually we'll see methylmalonic acid elevate first, maybe homocysteine in an early B12 deficiency, although the earliest B12 deficiency, there's a lab marker that we can't even get right now, but hopefully it'll become available at some point. And it's holotranscobalamin 2, but that would be even earlier stage deficiency, but we don't have that available. So the earliest stage, we tend to see MMA elevation and or homocysteine elevation. Then later we'll see B12 in the blood being a little low, less than 400. And then even later, much later, if it keeps progressing, then we'll see on a CBC, we'll see MCV elevate and red blood cells go low.
Right. And so if those are all things we can look at, even if you have a normal B12 as the potential indicators of a B12 deficiency. So all of that to say is you just can't look at a B12 and assume it's a piece of the puzzle, but you got to look for the rest of the pattern. And some things are early markers of B12 deficiency. Some things are late markers of B12 deficiency, but probably the worst marker by itself is a serum B12 to take a look at. Okay.
And people get confused on that serum B12. Sometimes they see it high and they think they need to stop taking B12. And there's because the lab flags it with an H and circles it in red like it's a problem. And if their doctor doesn't know that there's no toxicity threshold for B12, they might tell the person to stop taking B12, even though B12 could still be low with a high blood B12 level. And I've seen people stop themselves from taking B12 because they see a high level on a lab. I've seen doctors tell people to stop taking B12 because of a high level of B12 in the serum. And there is, even though the lab flags it as high, there are no known toxicity thresholds for B12. That's not the same for other B vitamins. So B6, high levels actually can cause problems. There are many B vitamins and minerals and things that have toxicity thresholds, so you cannot generalize this out. But for B12 itself, we do not see a known toxicity threshold, so having high blood levels is not a problem.
All right, everybody, we're back. And if you're watching this video on like YouTube or if you're listening to it, it's not going to be a big deal. But if you're watching this on YouTube, Dr. Miles and I are wearing different clothes. And so you might say, why would they change in the middle of a podcast? We did not change in the middle of a podcast. What we did was that conversation that we were having really started to carry on, and we didn't get through some of the rest of the topics we really wanted to discuss. And we really didn't get time to finish like a conversation that we were on. So we're back. We're going to finish this up. It'll be a longer podcast, but we're back to finish this conversation. So Miles, thanks for coming back on and finishing the conversation. I think when we left last left the conversation, we were really kind of deep into B12 and looking at different aspects of B12 physiology. We had talked about anti-parietal cell antibodies. We had kind of maybe give some indication as to how that might tie into people with thyroid disorders or even thyroiditis or Hashimoto's or other types of autoimmune conditions. Is there any like immediate points that you left that conversation with where you're like, I wanted to add this and I didn't get it before we kind of jump into the other pieces we want to talk about?
Yeah, well, I do want to bring in the vitamin D as well, which is actually a hormone and not a vitamin, but it's involved and there are receptors in those parietal cells for vitamin D, and those D levels are really important for even the relationship with B vitamins, B12, and sleep as well. Because I do a lot of sleep studies for people. We see sleep apnea as such a huge issue, and not just sleep apnea, but decreased REM sleep and other problems related to sleep. And we know that there's a vitamin D and B12 and some other B vitamins relationship with sleep. And we know sleep impacts energy and impacts all of the body's ability to regulate, and is going to translate into an impact on thyroid as well. So I think it's important to mention vitamin D and how, of course, today in the world, many people aren't spending as much time outside and getting as much sun exposure to make vitamin D at the levels that would be optimal. And so that we see that there's kind of a range of vitamin D that plays into this whole picture that a lot of people aren't in. Either they're too low or they're supplementing and they get too high. Sun has the ability to not get too high because the skin will inhibit eventually. So with some exposure. Yeah.
So let's do this. Let's break it down a little bit. And we may have some differing views on vitamin D and vitamin D physiology. So that may get us into a little spirited conversation as well. But let's do this. Let's talk about what vitamin D is, right? Let's talk about how we get to what often is measured. We'll talk about the active, the inactive forms of it, and then we could talk about what some of its roles are. But I think from my perspective, one of the challenges is that almost everybody is being told that they're deficient in vitamin D, and that everybody needs to be bombing themselves with vitamin D. And you can take as much vitamin D as you want, and there's no negative impact on it, like 50,000 IUs a day or 10,000 IUs a day. And despite taking high levels of vitamin D, people are still vitamin D deficient. So when you start to say that everybody's deficient, therefore everybody needs it, to me, that creates a little light bulb that goes off in my head and says, well, maybe we don't really understand. Are you there?
I am back. Yes.
All right. Where did I leave off? It looked like I froze. Let me make sure I close everything here.
Yeah. You were saying that.
All right. Yeah. Let me go back and do it because I know where I'm at. I'll cut this part out. So are we still good?
Yep. We're good.
All right. So Miles, one of the things before we get too much into the weeds with vitamin D, let's spend some time kind of talking about what vitamin D is, how we get vitamin D, what's vitamin D, what are we measuring in the blood work, so that we can start to help people understand what it is, because we see a lot of people are chronically deficient in vitamin D. Everybody's being told to take vitamin D, and at some point you have to start to ask the question, why is everybody deficient, right?
Yeah.
And maybe we're not looking at it right. So tell everybody, like, what is vitamin D? Where do we get it? And then maybe the conversion of it.
Yeah. Yeah. So vitamin D really is not a vitamin. It's a hormone, and it's a hormone that's generated naturally through sun exposure and sun contact with the skin. So it's a hormone like thyroid is a hormone, like estrogen is a hormone, like testosterone is a hormone. And it's the sun exposed to skin creates that hormone or generates that hormone. And typically most people don't get vitamin D from the diet, although if you take cod liver oil, there's going to be a little bit in it, or if you drink milk, it's going to be maybe they add a little bit to it, but normally it's produced naturally through the UVB light and the skin and a reaction that happens. So that's what vitamin D is it's actually a hormone, and it's made from skin being exposed to light.
And what's the base? And that's the base to make vitamin D is something called cholesterol, right?
Yeah.
So we get sun converts the cholesterol into the skin through a couple processes. We won't bore everybody with the fancy names. And you make this thing called vitamin D. As Dr. Miles says, it's a hormone. Now we've made this vitamin D, or we've taken some vitamin D supplementation, and then what happens?
So there are receptors for vitamin D all over the body. So there are receptors in the teeth and the salivary glands. There are receptors in the parietal cells and receptors in the stomach sphincters. And there are receptors for vitamin D in all sorts of different places in the body. It goes to the liver, it goes into the bile, it permeates many aspects of the body, and it helps calcium to be absorbed better from food into the blood. And that's why sometimes parathyroid hormone gets confused with thyroid hormone. Parathyroid hormone is a hormone that takes calcium out of the bone and puts it into the bloodstream. Vitamin D and parathyroid have an inverse relationship. In fact, they calculated the average optimal vitamin D level by maximal suppression of parathyroid, because you don't want to be taking too much calcium out of the bone, because that's going to lead to bone issues. And because vitamin D has a role in bringing or absorbing or increasing the absorption of calcium, then increasing vitamin D levels tends to lower the need for the body to produce as much parathyroid and pull as much calcium out of the bones. So that has to do with the function of vitamin D, has to do with calcium handling in the body as one of a few functions.
Okay, so for the listener, we're talking about vitamin D, but that's not what's impacting your cells. That's not what's your doctor's measuring. Vitamin D is kind of what's made in the skin. It's what you're taking as a supplement, but really what has to happen is that vitamin D needs to get converted, right? And so vitamin D needs to get hooked up with an Uber driver. We call that a vitamin D transport protein, and that gets trucked off to your liver. And at your liver, that vitamin D, hormone D, vitamin D, is converted to something that's called 25-OHD, which is what your medical doctor and maybe your functional medicine practitioner is actually measuring. And that 25 vitamin D is considered the circulating reserve of vitamin D, right? That's what's available in circulation. It's constantly circulating, bound to this binding protein to be able to get, so that you can take it to the tissues and then it be used. The vast majority, I would say, of vitamin D, when we think about what's the primary function, it's about calcium regulation, as you were talking about. So when the body says, hey, calcium levels are a little bit less than they should be, that lower level of calcium triggers the parathyroid gland to produce parathyroid hormone. Parathyroid hormone then tells the renal system, your kidneys, to convert that 25 vitamin D to 125 vitamin D, which is now the active form of vitamin D. And it's that activated form that binds to our vitamin D receptors that Dr. Miles said is like all over the place, killing immune cells everywhere else. And when that 125 vitamin D binds to those receptors, that's what triggers the actions of vitamin D when it binds to vitamin D receptors. Now, So when anybody talks about it, usually they're talking about that, right? So now I've bound vitamin 125 to the receptor. That brings more calcium into the bloodstream and get more calcium pulled out of the bone to normalize the calcium levels in the bloodstream. And the body kind of defends the calcium levels in the bloodstream. If the calcium levels are optimal, then we get the parathyroid hormone is then shut down, and we should have reduced conversion of 25 to 125 vitamin D because, hey, we've got enough calcium. But there are a whole bunch of other things that may cause 25 to be converted to 125 because there's a need for 125 vitamin D because of its immune regulating effect. So can you talk about like what might some of those things might be that might help drive that conversion of 25 to 125 vitamin D?
Yeah, so that's going to be the calcium handling, of course, is one of the major things that you mentioned that's going to be the number one thing. But of course, there is going to be infections, other things that are related to immune function are absolutely also going to impact that conversion. It used to be thought that doctors used to think, oh, I can give D2 and that's going to be converted into D3 appropriately. And that actually caused problems. I don't recommend anyone take D2 because it really is it can be actually harmful. And so D3 is much safer to supplement directly with. But yes, immune function issues or chronic infections would be one of the other major impacts.
Right. So where's that occurring? Like what's doing that conversion? And from my literature research, immune cells actually have the ability to convert 25 to 125 and raise those levels, right?
Yes.
Now, one of those things that's really important for every step of vitamin D metabolism is something called magnesium.
Yes.
Because to convert vitamin D to its 25-OHD kind of circulating storage form requires magnesium. To bind vitamin D to the binding protein requires magnesium. To convert it to 125-OHD requires magnesium. To deactivate vitamin D requires magnesium. So it's really important, especially at least from my perspective, I'll let you talk about it as well. If somebody already has a magnesium deficiency and now you're bombing their body with vitamin D, now you've got an issue. Your body has to say, okay, what do I do with this surplus of vitamin D? It's got to go somewhere and I got to manage it because now that becomes an issue and that could potentially lead to further issues with magnesium deficiencies, right?
Absolutely. Yeah. Important relationship between vitamin D, magnesium, and vitamin K2 and B vitamins all have a relationship. And this is just true for the body. Their interconnected systems are things really have this intricate way of moving together. And so another aspect of vitamin D is that you need magnesium, absolutely, for conversion. And then once if those calcium levels start to build up in the blood and get a little too high, then it's vitamin K2 that takes that calcium that's excessive in the blood and brings it into the bone. And one concern I have for people who supplement with vitamin D over a long period of time who may not have adequate vitamin K2 levels is calcium buildup in the blood, which could then cause other issues or deposits in the body. And so I have concern when people take large doses of vitamin D for a long period of time. In general, if they get their levels too high, I have concern. But if they get their levels too high and they don't have vitamin K2 or magnesium to balance that out, I also get concerned in those cases. So we really do want to have that balance between D and magnesium and K2, and then the B vitamins play another different role as well in that physiology.
And there's also some literature that shows that you really need to have vitamin D and vitamin A in balance. And if you take mega doses of vitamin D, you may reduce your levels of vitamin A.
Exactly.
And for the listener, you're like, oh my gosh, but why does that become important? Because vitamin A is critical to a lot of signaling issues inside the cell. And it's really important when it comes to iron physiology, and iron physiology is critical to health and well-being. So let's talk about
immune function too.
Absolutely. Right. So let's talk about why somebody, first of all, let's talk about how you look, or how would you monitor somebody's vitamin D status?
So I like to look at vitamin D in the blood, and I like to, there's the immunoassay that's usually used for vitamin D is not the best way of measuring it accurately. And so it's fine. It's what is ordered most of the time. It's better than nothing. It is typically, most people are getting the right form of vitamin D measured, that 25-OH, but the 125-OH can be measured via immunoassay, or it can be measured via LCMS. The LCMS method is a better and more accurate method of measuring it, if possible. If people can get that, that's a little better. That's my preference. And then I like to make sure to also look at parathyroid hormone as well, because I want to see where the levels of parathyroid hormone are at. And I like to see the levels of parathyroid hormone in the lower half of the range. If the levels of parathyroid are in the upper half of the range, then there may not be enough vitamin D in order to be increasing that calcium into the blood. And then, of course, I like to measure as well magnesium and get a sense for what's going on with magnesium. And a constellation of those, the vitamin D level, the parathyroid level, and ideally a red blood cell magnesium level, are going to together inform a good sense for what's going on with vitamin D, much better than a vitamin D alone.
So are you looking at 25-OHD and 125-OHD?
No, just 125-OHD is really the one that we're looking to. So when we're measuring, we want to measure that active form, and ideally we want it measured with the LCMS technique and not the immunoassay. So that's ideal.
I measure both along with RBC magnesium, and if those values are out or calcium's out, then I'll do the look at the parathyroid hormone. But
yeah, it's actually not, it's not the 125-OH. It's more the 25-OH that we're looking at. But yes, we can get both of them as well and take a look at both.
And so typically what's only measured is the 25-OH, because it's considered it's the dominant form, and right, that the 125 is a smaller, in a smaller quantity typically. But I like to look at both, because what I want to know is, especially in somebody who's chronically low in vitamin D, is where's it going? Yep. Right now, we don't have the ability to measure the deactivated forms, 24-25-OHD or 24-125-OHD, which are the deactivated forms. But there is some science, Dr. Navio actually talks about this, that under a cell stress or cell danger response, one of the things that the body does is it increases the deactivation of vitamin D. And so why is that a big deal? Well, if part of a cell danger response is to downregulate vitamin D, maybe the deficiency we see is not the problem, it's the adaptation. So I like to see both. Dr. Kell and others talk about how chronic infections are things that will continually drive that conversion to 125 vitamin D. And so I think it's good to take a look at those values. And I look at it maybe a little bit differently than you. If I see a chronically low 25-OHD and a chronically high, really high elevated 125 vitamin D and calcium is normal, then I am not in a rush to give that person more vitamin D. I'm more taking pause. Yeah. The other thing that we have to be considerate of, we talked about, do you have enough magnesium to manage what's in there, right? Are we creating, by bombing the body, are we creating other issues? And then so I'll always look at iron regulation as well. But there's some interesting indications that people who are heavier, have more body fat, are going to have a lot of their vitamin D go right into the adipose tissue. Have you seen that literature and research?
I have not, but that's fascinating. I'd love to take a look at that. Yeah.
So one of the roles, you would think maybe it's just storing the extra vitamin D, and it doesn't turn out that that's the case. It turns out that the fat cells use that 125 vitamin D to help drive, kind of manage the inflammatory mechanisms that are in the cell, and to trigger more leptin to help signal to the brain that, hey, whoa, we got enough food in here, don't eat anymore. And the other thing that's interesting is that 125 vitamin D can be used to make more adipose cells. For the person who's listening, it's more fat cells, essentially. And so this wasn't done in humans, but it was an interesting study done in mice, which is when they took away vitamin D, those mice could not get fat. Interesting, right?
Yeah.
So now you say to the person, how does that person continue to gain weight, even if they're not maybe consuming what we think they should be? But if they're doing, maybe that vitamin D that they're consuming to support their immune system is going into their adipose tissue and potentially causing replication of fat cells, allowing more stuff to get stored and potentially driving more of immune inflammatory process. Just food for thought, right?
Yeah.
But it always concerns me, and I have a lot of clients, and I'm sure you do, who are like, I take 5,000, 10,000 IUs a day, and my vitamin D is still 28. It never comes up. Well, maybe there's a reason for that, right? So
Yeah.
for the person who's listening to this, especially in today's world of COVID, and everybody says, hey, you need to take tons and tons of vitamin D, I say be a bit cautious, right? During this time of the season, for sure, your vitamin D absorption from the sun is going to be diminished. But we also, from a functional medicine standpoint, we have to look at, correlation versus causation, which we talked about earlier in the podcast, which is the low vitamin D the problem, or is it just part of kind of the adaptive physiology? Okay. So we can beat up on that a little bit more if you want. By all means, if you have any, if you want to debate any of those points, I'm good for it. But
no, I think
what's your thoughts there?
Yeah, I think those are good points, and I think that there's absolutely a big role that vitamin D plays in health, but it's not just low. It can be too high. People can take too much, and it is a constellation of these different elements of. First off, I think people confuse that the only role of sunlight is vitamin D. That's not true. There's many benefits of the spectrum of light, and we know light therapy now. We know near infrared exposure and red light exposure has positive effects on mitochondria. So first, I want to say that if you're not getting sun, vitamin D isn't a good substitute just for you. That's not the only thing that sun is providing. So that's a first thing to make people clear about, is that sun does a lot more than just give you vitamin D. Second is that the vitamin D levels are related to other vitamins and minerals as well. And so looking at it as a broader pattern and constellation is important, and not just saying your vitamin D level needs to be this and you need to take higher and higher doses until it's this. We really need D and K2 and A and magnesium and B vitamins all have a relationship together. And then you add the immune function piece and chronic infections. And so it really does become a little bit complicated. So I don't want people to feel like it's too complicated, but I also want to make sure that people understand that if they're able to take some vitamin D and they're under the guidance of a practitioner who knows these constellations, who's able to make sure these other things are in check, that can be wonderful. But if people are self-guiding it, then no, it's a bit of a complicated picture, and it's important to do a little more research to make sure that you're doing it correctly and safely, and you're not going too high, because too high does actually cause problems as well.
Absolutely. And I think what is really important from the layperson perspective is, do I need it or do I not need it? It's kind of a black and white thing. And from a functional medicine perspective, from a clinician standpoint, we should be asking the better question for our client, which is, okay, why is your calcium chronically low? Why is your vitamin D chronically low? Why do you always need those things? Even when calcium is low, you have to start to ask the question, like, where is it going, right? And even inside, we know that too much calcium inside the cells is potentially problematic and toxic. So is it going in the cells? Is it not being absorbed? Or should we just kind of keep bombing the system and keep pushing it and pushing it? And so it becomes really a complex issue. But to make it simple for the listener to say, do I need it? Do I not need it? You might need it. The times that you might need it are definitely the times when you have less sun exposure, and it's, that time of the year where you're not getting much of it. But if you're taking vitamin D and you're getting sun exposure and your values are still low, the solution is probably not an endless supply of vitamin D supplementation, although especially people who sell vitamin D would say, yes, it is. The question, there needs to be other questions there. And I think we're both probably in agreement with that. And it doesn't matter whether it's vitamin D or B12 or thyroid hormone. If you have to chronically support the blood to make it look pretty, and as soon as you stop, it goes back to what it was, you haven't fixed the issue. You've only essentially painted the moldy wall, right?
Yeah.
And so if I came to Dr. Miles' house and he said, listen, I've got a moldy wall, I want you to fix it. And I gave him a can of paint and a paintbrush. And I said, listen, Miles, if you want that mold that wall to look good, every morning when you get up, take that paintbrush, paint that, it'll look good. Tomorrow morning, you're going to have to do the same thing, but that'll fix it, right? No, I mean, we wouldn't accept that, right, if in our homes, and yet somehow we sometimes default to that because, well, somebody told me that that's the way to fix it. You can fix the value, you may not fix the problem, right?
Yeah,
So,
really important.
I want to pivot a bit because one of those things we wanted to talk about was something called CIRS.
Yes.
Okay? So can you explain to people what CIRS is? And then we'll get into that a little bit, and then we'll talk about how that might relate to thyroid physiology.
Absolutely. CIRS, or CIRS is how that's spelled, stands for Chronic Inflammatory Response Syndrome. It essentially is saying that a person is chronically inflamed as a response to something. And that something typically is an accumulation of toxin in the body. And that accumulation of toxin in the body that crosses a body burden threshold, the body can tolerate a certain amount of toxin, can store toxin in cells, can store toxin in less desirable, but organs or the brain. And there can be a threshold of tolerance, but once that threshold is crossed, that can lead to this chronic inflammatory response where the body's consistently releasing these cytokines, these inflammatory molecules. And it's not always the normal obvious ones that are commonly tested, like HS-CRP, or high sensitivity C-reactive protein is a commonly tested inflammatory marker. CIRS patients may not express HS-CRP, that may be normal, but other very specific inflammatory markers may be highly elevated, like TGF-beta1 or C4a. And so there's often a defect in the complement part of the immune system, a genetic predisposition for the immune system not to be able to recognize certain kinds of toxins as threats and get rid of them appropriately, as most people's immune system's able to say, oh, tricosethine is this toxin from black mold that's very toxic, and the immune system recognizes it and goes after it and gets rid of it and takes it out of the body. But for genetically predisposed individuals, there's about 1 in 4 who have a genetic predisposition for the immune system not to recognize and get rid of those toxins, as well as the other 76% of the population. and then that gene may or may not express, and then there's environmental exposure that has to happen. So it's a little bit of a can of worms. But if someone has the genetic predisposition and they're exposed to toxin and the gene activates, then they can accumulate the toxin, go into a chronic inflammatory response syndrome that can contribute to immune dysregulation, autoimmunity, joint pain. It can contribute to mental emotional issues, depression, anxiety, can contribute to insomnia. Many different kinds of symptoms can have that as a root cause. Now, there are many other root causes also that can cause those same things, but that's one root cause for many of those symptoms.
So if we're saying that CIRS is a chronic inflammatory condition, right? Chronic inflammatory response syndrome, as it's known, and you're saying the immune system is seeing this and reacting to it. Somebody might say, well, if it's an inflammatory issue and it's an immune system response, is what the immune system doing inappropriate? I mean, if I have a toxin and my immune system's reacting to it, is that truly inappropriate? Is that inappropriate? Like if I have a toxin, shouldn't I get rid of it? So how do you differentiate whether that inflammatory response is an appropriate response to a toxin or it's an inappropriate response to a toxin?
Yeah. So there's data and research that look at one of the genes. It's called the HLA gene, and particularly the DR and DQ parts of that gene are associated with the ability to recognize appropriately and get rid of the toxin from mold and from Lyme and certain other toxins as well. And if people have a mutation or a change or a polymorphism in that gene, then if that's expressing, the immune system is not appropriately handling the recognition and disposal of that toxin. If that gene is functioning normally, then the immune system, it's good that it will find that toxin and get rid of that toxin. Normally, that's the mechanism by which the body and most people handle toxins like mold toxins, is the immune system is able to identify them as a threat and get rid of them from the body. It's those 24% of the population, or about 1 in 4, who have the genetic predisposition in this HLA gene that research says that the immune system is not able to adequately recognize and get rid of. So there is a dysfunctional immune response to the toxin in that percent of people. And that leads to this chronic inflammatory response that's not resolving by the immune system's function alone without some additional intervention typically.
Okay. So for the person who's kind of listening to this, it's difficult to understand, right? Is it an immune response or isn't it an immune response? If there's a lot of inflammatory mechanisms going on, isn't that an immune response, right? So a lot of people are exposed to toxicants, right? A lot of people exposed to organisms. And at some point in time, for some people, the immune system sees the toxin and gets rid of it. For other people, the people see the toxin and potentially have an excessive response. And I think what you're saying is that excessive response or abnormal response results in excessive inflammatory and immune response to that toxin versus, hey, that's a toxin, shouldn't be here, let's get rid of it, versus, oh my gosh, that's a toxin, ramp up all the defenders, bring the army, bring everybody, we got to get rid of this thing and find it wherever it is. Is that maybe a simple explanation for what's going on?
Yeah, and I just add the piece that in the chronic inflammatory response syndrome, people that not only is it an excessive response, but it's a non-resolving response, meaning that it's not excessive for a short period and then the toxin is disposed of. It's that it's an excessive response and the toxin is not disposed of, both. So there's this sense of there being all this inflammatory byproduct, but it's not getting rid of the reason why it's there, like it does in normal people, the disposal mechanism is impaired. Does that make sense?
Yeah. So there may be something going on with the detoxification process that you can't get out to begin with.
Exactly.
So somebody might say, well, I think I have mold exposure, right? And so how do I know if my mold exposure is, if I'm exposed, and how do I know if it's really a problem, right?
Yeah.
Because you could have two people in the same house. One has mold exposure, the other one has mold exposure. One seems to be symptomatic due to it, another one does not. So what's the best way to evaluate? Let's start, because we brought it up, let's talk about mold. If somebody wants to know if they have a mold exposure, what's the best way to evaluate that? And how do we determine if that is a thing that's triggering an immune response?
Yeah. First, I want to decouple mold as bad in general, because some molds are not toxic. So it's important to know that mold is potentially toxic, but not always toxic. And there are a lot of outdoor molds that aren't toxic at all. Some of the indoor molds that grow in water damaged buildings, many of them are toxic, but not all of them also. And it is estimated that about 1 in 2 American homes is water damaged, and that's not always visible. Schools and churches often, especially with flat roofs, have big issues with water damage. So water damage is not, and it's not reserved to places that are humid. People think, oh, if I live in a humid place, they did a trial looking at different levels of humidity, and they couldn't find that strong a correlation between it only happening in humid places. We run plumbing through walls, we have roof leaks. There are lots of reasons why mold can happen in a variety of different environments. So there are a lot of people who are exposed to mold, but not all of them get ill. And so, like you're saying, you could have 4 people living in a home and 1 is ill. The home usually doesn't get blamed. The part of the reason is because it is only 24% of the population that has the genetic predisposition to have that dysfunctional immune response. Another part of the reason is that even if someone has that genetic predisposition, it might express or not express. We know epigenetic variables might lead to a gene expressing in one person, but not expressing in another person. So is there the gene present, and then is the gene expressing? And the expression of the gene has to do with diet and lifestyle and stress levels and exposure to infections and other triggers. So often it might be that someone lived in a childhood home that had some mold and it wasn't a problem. They had the gene predisposition, but it wasn't expressing. And then later they had this constellation of other things happen, some big stressors, some traumas, and then maybe an infection. And then all of a sudden that gene starts to express. And then as that gene's expressing, now they're accumulating and holding on to and not getting rid of those toxins. And then they're getting ill as one person in a home. And so if a person is suspecting it and they're wanting to know if it's mold as one of the causes, and I say one of because usually there is this constellation of other things that leads that to become a problem. But if they want to know if that's one cause, then testing the genetic is one part. Testing certain inflammatory markers that we know are pretty specific to usually being elevated by mold is another way. A visual test, that there's research that parts of the visual system and brain are impacted by mold toxin. So there's a visual test that people can do at home from their computer that's pretty simple, that can give it's not diagnostic, but it gives a general clue or a sense that maybe they should dig a little deeper and look a little deeper. There can be a dust sample on the home itself to see if there are spores of the toxic kinds of mold that can also indicate if a person's being exposed to mold. Those are just some of the elements of how a person can start to get a sense for, and then of course, if they feel better when they're not in the home, especially if they're spending a few days not in the home. And that's confounded by maybe they're in less stress because they're on vacation. So it's not a perfect trial. And Some people who are chronically inflamed from mold, it's historic and not current, meaning it was their previous home that built up the toxin level to be chronically inflamed. They're not in current exposure, but they're still dealing with the symptoms even after leaving a moldy home because the body is still in this chronic inflammatory response and that hasn't resolved.
Yeah, so lot of good information there, and I'll add some things in there. So when Dr. Miles is saying kind of all these things, to me, it goes back to the thing I talk about all the time, and that's the load, right? And so you can have genetics, you can have all these things, but why does one person in a home potentially have problems and somebody else doesn't? It really comes down to the load. He was talking about that you could have a gene and it expresses or doesn't express, and what's the difference? Well, we talk about you can't change your genes, but you can change how those genes are activated or deactivated. We call that epigenetics. So all the things in your life have an influence. We've been living with mold and for, I don't know, a couple million years or so. And so what really does change? Well, maybe the toxicity of some of these molds is worse, but there are people that live in homes that don't have the toxic molds, right? And they still seem to have some sensitivity to the like really bad molds, but yet in an environment where it's just kind of common molds that aren't supposed to be toxic, they can still have some issues. Why would they have issues? Because maybe they already have an excessive burden of stress, and now you add one more stress to the system. So I look at the load and not so much toxic or non-toxic. Obviously, there's some really bad actors out there that can create some problems. There is a test, I think it's called the visual acuity test that you can do, right? I think that's the name of it, right?
Visual contrast sensitivity, or VCS for short.
VCS. So that test you can do, and that can help you get an understanding if there's some compromise, but it doesn't necessarily mean you have a mold toxicity issue, right?
It doesn't. There's research correlating it, so it makes it a greater chance that that's a part of what's going on if there's a positive test, especially on the biotoxin part. But it's not diagnostic in and of itself. So you need some additional data as well before determining that it's mold that's causing an issue.
But there's other things that could influence that visual test.
Yeah, we know nutrient deficiencies and gut issues can impact it. We know infections can impact it. We know other kinds of toxin exposures to things like cigarette smoke and certain other things can also play a role. So
yeah, that kind of makes my point that, hey, you see altered physiology anytime there's an excessive stress load. The other thing that I think we need to touch on there too is that when we think about testing, how do we look at these? So I'm going to ask you a couple questions, and then how there's urine tests, there's maybe blood tests, antibody tests, but you said something where when the person leaves the environment, they sterilize their environment, why do they still have this same symptoms even though the thing is gone? Maybe it wasn't the mold, maybe it is, but why are they way more sensitive? I think if we take a look at the work of Dr. Vujidani has done recently a bunch of great tests at CIRS labs, and one of the things I think that he kind of talks about, and I think it makes sense for a lot of our clients, is the immune system can become imbalanced or dysregulated. If it can become plasticized to behave in a certain manner, and when you have a stress overload and we shift that immune system to behave and maybe in a protective way early on, but then the stimulation is chronically there, now the immune system kind of becomes plasticized. That's just the way it is. It's in a hypervigilant state. And the real things, the toxins, the molds, those things could still go away, and yet you still have this excessive response. And not putting words into Dr. Vujidani's mouth, but I think what he kind of talks about is, hey, sometimes the issue is no longer the Lyme, the co-infection, the mold, the thing that you're trying to treat, especially if you've treated it 4 or 5 times and you still have the issue. The issue may be that immune system may really be stuck in that imbalanced or dysregulated state, And the strategy isn't necessarily to try and continue to kill, but to change, to help that immune system come back into a more normal balance. And so he talks about that quite a bit. If you're interested or want to geek out, you can go to cyrexlabs.com. I don't get any money for cyrexlabs.com to say that, but they do have a ton of information about the type of testing. And Dr. Bujidani is well published, and I think well respected for all the work he does. But if somebody wanted to know if they have a mold issue that may be creating part of their CIRS syndrome, right? Or maybe the cause of their thyroid issues. I mean, many times people say, hey, I think I have a mold issue that may have triggered my hypothyroidism or my Hashimoto's. I talk about this all the time. I'm sure you do, that any excessive stress could be the trigger of a thyroiditis expression, right? So it could be toxicants, it could be organisms, it could be a lot of things that initiate that thyroiditis. And I always look at through the lens of the cell danger response. Like anything that activates the cell danger response could result in thyroiditis, because I look at it like, whoa, we've got danger. Cells typically operate in manufacturing mode where they want lots of T3, or the cells operate in a cell defense mode where, hey, we need to slow down the metabolism. We want to decrease the T3 state because we want to turn off the manufacturing and turn on the immune response. And so that can lead to a thyroiditis. But if somebody wanted to know if they had a mold issue, there's urine tests, there's blood tests. Like, what's your thought versus urine versus mold versus blood versus other? What do you think is one of the best way? What do you think about the urine tests for mold toxicants? Great Plains Labs, Genova has tests for those things. What are your thoughts on those?
Yeah, so the urinary tests are looking actually for the mycotoxins themselves in the urine, and they're good, but there's a bit of a problem, which is that, are there mycotoxins in the urine because you're properly disposing of mycotoxins, or are there mycotoxins in the urine because you have an excessive load? And that's hard to tease out. And there are mycotoxins in foods. So are you properly disposing of the mycotoxins from foods versus breathing in air in a water damaged building? And those are very different, because breathing in air in a water damaged building is more likely for those toxins to get into the bloodstream and tissue versus from food. And so there's some nuance to those urinary tests where they can be one consideration in a bigger picture of other elements. But I like to see the blood test for the genetic predisposition is a nice one to see if the person has that. And I also like blood tests for certain inflammatory markers that tend usually to elevate with exposure to biotoxin from a limited number of sources, and they don't tend to elevate from inflammation from a lot of infections or other things. So there's some they're not completely specific only to mold toxins, but they're pointers. They're more likely to be elevated because of mold toxin than they are other things. So these are blood markers like TGF-beta1, C4A, and MMP9. These are a few of the inflammatory markers that tend to be elevated. Melanocyte stimulating hormone tends to be low, or MSH. And then there's often a sinus infection referred to as MARCoNS, which is a multiple antibiotic resistant organism, a gram-negative staph organism in the sinuses that we see growing in many people who have been exposed to mold. It can also be there in people who haven't been exposed to mold, but if it's there, it's potentially causing issues. And so I like to have a few different kinds of tests, and the visual contrast sensitivity test, and then look again, where just like with the vitamins, we want to look at a bigger picture pattern, and we want to get a sense for, are we seeing multiple angles that are all pointing to the same root cause or causes as part of what's going on? And then if we see three different things that are all pointing towards a likely mold issue, that's going to be a lot more powerful than just one test, for example.
Yeah, and I think that becomes important. And I would say for the people that are listening, there are, everybody's has some different ways of looking at how to identify these things. And there are some labs now that actually are doing antibody testing for some of those things that you could say, hey, look, if you had two people and it was in their urine, one's sick, one's not, you could say, okay, if we run the antibodies, if the immune system is actually producing antibodies, and we can't test everything, but if you're testing kind of these most common things and the body's producing antibodies to those things, then your immune system is identifying that, like, this is a big deal.
Yeah.
We need to get this out of here. When it comes to the urine test, I know it's a really common test to get done. And I don't think it's necessarily a bad test. The question comes down to exactly what you said, which is it because I'm exposed and I'm getting rid of it? Like, I look at it, if you know you're exposed and it's in the urine, that's awesome, because you're probably getting rid of it, right? If you're exposed and you're sick and you're not seeing it in the urine, to me, that would be way more concerning. And then that's when, definitely, if you haven't done some of the other testing, you might want to go, oh, I'm not exposed. You might go, I may be exposed and I can't eliminate this stuff, which is what Dr. Miles was saying right in the beginning.
Yeah.
But that's what I really wanted to have you kind of drive towards, that is, hey, the urine test on its own doesn't tell us if that is your issue, right? It may be that you have some exposure, but that's probably why your spouse has the same stuff in its urine, but doesn't have an issue, because his immune system has said, hey, it's not a big deal. Body's going to handle that. Immune detoxification pathways got that, no problem. Versus, holy cow, bring out the army, let's go find this stuff, and because it's super toxic. So it could be to me, you have to go another step beyond just looking at a urine metabolite type test, because it tells us a story, but not necessarily the story, right?
Exactly. Yep. I agree.
When we take a look at,
please log in through the Google Home app.
So when we take a look at how that relates to, and I kind of jumped in maybe a little bit early on that, but when you're talking about mold with people and thyroiditis and immune-based issues, somebody who's got hypothyroidism, has Hashimoto's, where do you typically start with that person? This is a person who's coming in who says, maybe I have Lyme, maybe I have mold, I don't know what's causing it. Like, obviously there's a method to the madness of where you're going when somebody comes to you with thyroiditis, or, hey, I've got chronic hypothyroid symptoms and I'm still not feeling well. So walk me through the process in your practice with somebody as to how you go about evaluating and assessing them to determine which direction you want to help them go to help them get better.
Yeah. So the first thing is we have people fill out extensive paperwork and certain research validated questionnaires before I even sit down with them, so that we have, for example, a questionnaire that's been research validated to be associated with a likelihood for exposure to Lyme, even though it's not diagnostic. It can give us a clue or a pointer. We also have a toxicity questionnaire that also scores, and that score can be a pointer towards toxic burden. And then we have a lot of questions that are asking if a person's known that they have any exposures or if they suspect anything. And then when I sit, and of course their symptom picture, their family history. And then when I sit down, I've taken a look at all of that paperwork, and then I dive in a little deeper into the person's story, and I try to get a sense for, from birth until now, what are the events, the exposures, the potential infections that stressors, the elements that may have created this constellation. So it may be that after talking to a person, that I say, well, there were multiple rounds of antibiotics before 4 years old, and that could have contributed to a gut dysbiosis. And then there was 3 adverse childhood experiences, and we know from ACE studies, or adverse childhood experiences studies, that predisposes to higher incidence of autoimmunity later. And then there was a home in middle school that had likely water damage and possible mold exposure. And then there was time outdoors with known tick bites, and there might have been some chronic infection. And then there was Epstein-Barr virus. Mono was contracted in high school. And then a person, when they became 30 years old, had a big stress, and then their symptom picture started at that point. And then we're taking an analysis on all those different elements and saying, okay, underlying it's seeming like toxic burden, gut dysfunction, and a chronic infection are the big 3 underlying players, on top of the stress piece that I think may be playing a role given that person's case history. So then we direct our testing towards those things that we see through that case history as the likely players based on that person's story, what they've been through, the questionnaires that they've filled out, and the going through their life experience. And so then we'll put together, it may be a Lyme and co-infections test, plus we might do some testing around some small intestine bacterial overgrowth, or a stool test including parasites and ova, especially if there was a lot of third world travel or developing country travel where a person got sick. So then we're piecing that together to choose that lab initial order. And once we do that initial order, then we'll put together whatever previous lab data they've already had with the missing pieces, like maybe they never got, maybe they've had a lot of lab data and a lot of things tested, but they never got parietal cell antibodies, they never got Lyme and co-infection testing. And so we're filling in those gaps of information. And I want to know also, what have people tried before? What have they been doing? What's their journey been like on attempting to heal? And what kinds of dietary changes have they made? Supplements have they taken? Protocols have they been on? Practitioners have they seen? Because I usually get people who've been to 5, 10 other people, and they've done maybe 3 rounds of gut treatment, a lot of gut testing. And I don't want to go through the same thing that they've been through and not get results because they've already done it 4 times and this is the 5th time. So I really look to say, okay, you've done that a few times, so that doesn't seem to be a big leverage point for you, even though it may be part of a constellation. It doesn't look to be a big leverage point for what's helping you to get better. So we're going to leave that alone for the moment, and we're going to focus on this other element that has not yet been addressed and test there and focus our treatment there first. And then we'll be adding in other elements as we go along and evaluating how a person progresses, both from the symptom perspective, as well as we pick a few markers that we're off and retest them as we go along to see if we're getting changes objectively as well.
Yeah. So the person sitting there like, hey, Dr. Miles, man, just tell me the one thing that's causing my thyroid issue, right? And then for the listeners, what I want you to get, right, that the simple solution, like Epstein-Barr causes hypothyroidism for everybody, that's not the likelihood. The vast majority of us have had Epstein-Barr, and for some people it may be associated. But the most important thing that I want you to get from this conversation that we've had is that the thyroid condition, at least from my perspective, isn't typically the beginning of the problem. It's the body's regulator of, wow, we've got a lot going on here. We got to shut down manufacturing and ramp up defense. And so what Dr. Miles went through is is very similar to what I do and many other functional medicine practitioners do. Is we've got to essentially kind of figure out how we got here. You've gotten yourself, if you have hypothyroidism, Hashimoto's, thyroiditis, whatever the condition is, you got here because of a load over time, okay? And so now what we've got to do is we've got to reverse engineer the process to say, okay, what are all of the things that contributed to getting to a point of excessive cell stress where your cells and tissues had to change from normal manufacturing physiology to chronic cell danger, cell stress physiology? That's what we're doing. And that's why when you go to see somebody who's doing functional medicine, I think doing functional medicine well, we're not looking at just your thyroid panel. We're just not looking at one marker by itself, but we're looking at your health history. We're looking at your health timeline, right? I often say that, Donkey, he was this philosopher who says to Shrek, like, ogres are like onions. You have to peel back the layers. Well, people with chronic health issues are like ogres. Or like onions. You got to pull back the layers to figure out how did we get here. And sometimes the things that are the most obvious things we see, oh, you've got dysbiosis, that must be the issue. And it doesn't work, right? Or you've done the same thing over and over again. That's when we have to start to say, that's the effect. It may now be somewhat contributory, but it's not the leverage point, as Dr. Miles was saying. You want to think about what's going on with you instead of as a thing or lots of separate things, more like a physiologic web of dysfunction. I call it a multi-system adaptive disorder. Once I'm into cell stress, I got to focus energy and attention towards the defense. I turn off energy to hormone regulation. I turn down energy to proper stomach acid and digestive enzyme output. Because really, if I'm running from the proverbial tiger, I don't need good digestion. I need to run, right? I need to be alert. I need to be hyper vigilant. I need my immune system to be like, oh, let's go. We got to find whatever this is. And so it's the idea of how we get somebody better is not with a protocol. It's about understanding the mechanisms, the pathways, and the most likely scenarios. Anybody can give you a thyroid protocol. It's probably not going to work. Everybody in functional medicine has their gut formula that they give. And a lot of times, sometimes it works, a lot of times it doesn't, because just putting a couple ingredients into the GI tract may provide some short-term benefit. But if it doesn't address the root cause issue, as soon as you get done the treatment, 2-3 months later, you're right back into the same place. So when you're meeting a functional medicine practitioner, I think it's really important to have somebody who's interested in your health history, who's interested in listening to what you've done before and what the outcome of those things were, knows your timeline of the story of how we got here, and then takes a broad look at labs and looks for patterns, not specific values, but patterns of problems that tell us, hey, the blood values of your thyroid markers are okay on paper, but you've got multiple markers of tissue hypothyroidism. We've got a thyroid condition, not at the gland yet, but at the tissue level. You've got markers of inflammation that are maybe not the traditional marker. Maybe you don't have high sensitivity CRP. And even on general blood chems, maybe your ferritin is really high. Maybe your uric acid is really high. Maybe your HDL is really high. Maybe your fibrinogen is really high. Maybe your homocysteine is really high. But your doctor only ran a CRP. Well, that's one of just on a basic panel, a number of inflammatory markers, let alone some of the inflammatory markers that Dr. Miles was talking about that almost no physician is going to run who's typically in an allopathic world. It doesn't mean they wouldn't do it, but it's just not part of the norm, and it's not part of the medical necessity. From a medical necessity standpoint, are you inflamed or are you not inflamed? Are you bad enough, I guess, to give you some immunosuppressant or some high-dose anti-inflammatories? If you're not, they're typically not digging further. So functional medicine should be about asking better questions. And I think whether you see a physician like Dr. Miles, you see a physician like me or somebody else, if it's simply, hey, here's my gut protocol, here's this, like you have a thyroid problem, we're gonna give you T3 because you're not converting it. I think we need somebody who asks better. You really want to look for somebody who's asking better questions. I think where people get stuck is they don't feel well on T4, and then somebody's increasing and decreasing T4, trying to manipulate the value like that's going to fix it. And when that doesn't work, they find another physician and says, hey, we're just going to give more T3 because that'll fix it. And I think what we really need to do is take a step back and say, why is the body doing this? Why is it adaptively potentially changed versus always blaming the body for just screwing up, right? I don't think we got here from 2 cells to be what we are because the body is that dysfunctional that it always just screws up. It's more about what the stress load we're putting onto it, how that influences our genetic expression and our immune system, creates this excessive cell stress that puts us into more of a chronic danger mode. And then we see the adaptive changes, that multi-system adaptive response and this web of dysfunction. And somebody wants to come in there and just pull on one little piece of the web and say, I'm just going to fix this little piece. But really what Dr. Miles, me, and others are doing is saying, hey, we already know, we totally expect that if you have a thyroid problem, you're going to have problems with your lipids. You're going to have inflammatory issues. You're going to have a gut issue. You're going to have a hormone issue. We already know that those are potential things that are going to happen. We know that all those systems are all intertwined, but what we're really trying to do is find a way to kind of grab a hold of that web of dysfunction. And what is the 1 or 2 or 3 things that we can start to do that has the biggest impact on changing the whole web, just as instead of just working out on a tangent. If you think about a spider web, if you pull in the middle, you influence the whole web. If you pull on one little corner, you may not see the whole web change. So we want to do what's going to have the biggest impact on the web. And sometimes it's easy to identify what those things are. And sometimes it's way more complicated, right?
Yeah, absolutely. And I think it's so tempting for people to get into the one thing. And it's also tempting for practitioners who even understand some of the more complex nuances to want to get into the protocols and the order of operations. And people come and they ask me, oh, well, if I have a gut issue and a mold issue and a Lyme issue, then what order do I treat in? And because some people are saying, oh, you have to do the gut first, and then you do the mold toxin, and then you do the chronic infection. And it's still, it's not simple like that. Some people respond really well to going directly to chronic infection. Other people first really need to lower the toxic burden. Other people, if you don't resolve the gut, the others aren't going to make a difference. And so it's really bio-individual. People are very individual in the way that they are going to respond to treatment. And so I know it can be overwhelming, the level of complexity and all these elements. So I want people to make sure that you understand that it doesn't, even though it's complex, it doesn't have to be excessively. It doesn't mean you have to work on everything at one time. It doesn't mean you have to. Usually doesn't work, right? Yeah. So it's not like you need to do these 12 practices and take these 36 supplements and do. It's not. That doesn't work. That overwhelms the system. So a good practitioner can look at this complex web, do testing, look at the patterns within the testing, and then say, okay, here are the 1 or the 2 or the 3 elements that we're going to be focused on and target first. We're going to see how you respond and how the labs respond, and then we're going to tweak and hone. And it's probably not going to be right on the first try. It's probably going to take, like you said, the layers of the onion, but it can be step by step. It can translate fairly simply into, okay, here's step 1, here's step 2, here's step 3, here's what we're going to focus on first, here's how long we're going to give it, here's what you should be seeing or experiencing if we're on the right track. And if we're not, we're going to tweak, we're going to hone, we're going to look again, we're going to move and dance. It's like a dance to work together in that way. So I want to make sure people understand that it's not, even though it sounds overwhelming, once we get in, once we sort through it, then we can look at creating step-by-step processes to, like you said, get to the center of the web, and it's always an educated guess, and it's always going to have a level of you seeing your responses, and there's usually going to be some modifications that are going to have to happen over time, and some layers that are going to have to be pulled away.
Yeah, and I like a strategic approach, right? So I like one or two things at a time, layer them in, see what the response is, tweak if we're using supplementation, like let's tighter it up, let's tighter it down. Does it make, it doesn't seem to make a difference. Okay. Versus the shotgun approach where you throw a whole bunch of stuff at somebody. I'm trying to fix your liver, your gut, your brain, sometimes too much. It's hard to understand, especially if you're not doing well. Sometimes that shotgun approach works. People are like, wow, I feel all better. And other times they're like, I feel terrible, right? It's too much at one time. And if you do a shotgun approach, sometimes you don't know what it is that you did that made that person worse. So I'm a minimalist. I like to do it strategically, use things, pull them back out, layer more things in, pull stuff out, so that we can use them instead of having somebody continually build their supplement arsenal and then show up that they're taking 45 or 35 different bottles of supplements per day and say, well, I don't feel good. What can you give me? That usually my first thing with a lot of people is, first thing we're going to do is we're going to start eliminating all the things you have incrementally, and you're going to see how you do. Well, why? I need all these. Well, if you need 25 supplements to feel this lousy, you probably don't need any of them. So let's get those out. Let's start fresh. If you remove something and you don't feel any different, great, let's keep it out. If you remove it and you feel like worse without it, that's important to know. And now I want to understand why. I want to understand the mechanism of why you may not feel good, because I may want to put that right back in, or I may say, now I understand why that made you feel better, but here's what we're going to do to address that, right? So we learn a lot when we give somebody a supplement or a dietary change. When they say, I feel better, we learn. When they say, I don't feel any difference, we learn. And when they say, I feel a lot worse, we learn. It doesn't mean that to treat what was inappropriate at any one of those, with any one of those answers, but we just need to learn what that might tell us based on everything else we know. Would you agree with that?
Absolutely, yeah. And I think practitioners have their different philosophies and approaches, and it's not that one's right, one's wrong. And I mean, there are people who are malintentioned and are doing harm, but that's not usually the case. Most practitioners are really good-hearted people trying to help, and their approach helps some people and not others. And so, I think the medical system has some intolerance and some name calling and some my way is the best way kind of attitudes. And I really want to emphasize that even though, for example, I don't personally use many antibiotics to treat Lyme, like I respect the practitioners who do, and I respect the patients who get results from that. And I want to be there for people who don't respond to that, who need or want a different approach or have a different philosophy. And it's sort of like I've become more and more intuitive over time as to, like, maybe this person would benefit from a shotgun approach, even though that's not typical. But this other person, we really need to go so slow, and we need to start with just very, very small doses. And this other person, we do need to do a full reset, stop everything, and maybe a little bit of fasting. And then we're putting things in, because they've become on such a cocktail, it's impossible to figure out what's doing what. And so there's absolutely this benefit to pulling things out, putting things in, tweaking and refining in a dance and a collaborative process where we're getting feedback of how a person's feeling. And the more I do this, the more I tell people, I don't think I'm going to get this perfect on the first try. We're going to start with some stuff, and we're going to see how you do. And we're going to work together on this journey, and it's going to be a journey. And I think that really is important for a lot of people, want that kind of approach.
Yeah. And for the person who's sitting there, and listening to this and going, yeah, but I'm sick and I want to be better now. We totally get that. The problem is, especially when you've worked with 4, 5, 6, 7, 8 practitioners already, you're frustrated. You've had enough. You've spent a lot of money. You've taken a lot of supplements. Nothing seems to be working. And you come to your 9th practitioner, your 10th practitioner, you say, I just need to know what I need to do to fix it. The problem is we don't know you well enough in the beginning to fully be able to say, oh, here it is. And more than likely, you've already worked with some skilled practitioners. They've tried a strategy, didn't work out maybe the way they anticipated. Maybe they were out on the edges versus the middle. But we understand your need for some help and a need to see some spark and some change. We totally understand. And I'm sure Dr. Miles or myself, if we could give you the magic supplement that would do it, I would do that in a heartbeat for people. But the reality is, especially the longer you're ill, the harder it is, because the web becomes more and more complex. So it's harder to get somebody better sometimes. And typically when you're having chronic health issues, it's not something that really started last month when you got diagnosed. This is usually decades of issues, and we have to allow the body time to actually not only get rid of that cell danger response, but to actually help that, kind of hang with them long enough that their body can start to go into a healing mode. And that doesn't necessarily happen in the first month of care, but as the person's danger response goes away, you start to see changes maybe in labs or HRV before sometimes the symptoms are dramatically better, but the person's already on their healing journey. They just got to hang in there. But I tell most of my patients, usually within I think it's fair as a general statement, but everybody's different, that the average person who I start to work with, within 6 months time frame, they've seen moderate to significant change in their physiology, their signs and symptoms. We're seeing changes in labs. If I had somebody that I was working with and we saw no change in 6 months, I would probably be saying, hey, I don't have a strategy to help you. I'm missing something. We've got it. We have to get another set of eyes onto what's going on. I think I think that gives a person hope to say, okay, this may take a while, but if we're doing some of the right things, we should start to be seeing change in a relatively short period of time. Sometimes within the first couple of weeks, people are saying, hey, I'm noticing a difference. But I usually say in about 6 months time, you should be seeing a moderate amount of change if our strategies are working, right?
Yeah, absolutely. Yeah. Once we dig in with the lab data and do the case history, it's easier to give people a general time frame or window, but almost never should people expect to see massive differences in the first few weeks. I mean, it happens. I've seen it happen, but it's not the norm. It does usually take months, and to see full resolution may take years, but to feel on the right track and to feel like there are some substantial changes happening and that there's a movement in a trajectory towards feeling better should absolutely in 3 to 6 month window be happening, or else we feel like we're on the wrong track and we need to make some modifications.
Yeah, I totally agree with that. So Miles, we're getting to the end of another longer session. So we're going to wrap this up. I think we did justice to the topics that you and I wanted to cover, and definitely things of interest. So if somebody wants to learn more about you and your practice, where do they find your information?
So the practice name is Medicine with Heart, and the website is medicinewithheart.com, all one word. And there's a blog on there that has lots of free content that comes out regularly. So if people just want information, you can go there and go to the blog and just get information. If people want to get in touch about care in the clinic, then they can set up a free consult with one of our staff members to talk a little bit about how our clinic works and see if it would be a fit to book an initial consult with me.
Okay. I think you sent me some of your data. Is there some place they can follow? Are you on Instagram or Facebook?
Yeah.
Or those things?
Yeah. Facebook.com/medicinewithheart, Instagram.com/medicinewithheart, all one word. And then of course we also have a book. So there's Use Your Mind to Heal Your Mold and Lyme is available on Amazon. And then Stress Resilience is available on Amazon as well. So there are a couple of book resources for people who'd like that. And then there is also a practitioner training institute for other clinicians and practitioners who want to learn more about how to practice functional medicine and work on complex conditions like Lyme and mold. We have an institute at mindbodyfunctionalmedicine.com.
Excellent. Well, Miles, thanks so much for coming on the podcast twice, but we're condensing it to once. There'll be a long one for anybody who's listening. Anybody who's listened through the whole podcast, give us some feedback. I mean, this is probably the longest one I've done. This is probably close to 3 hours till we get it finished. But I like the longer format. I don't think it's hard to have a really nice conversation about any topic in under an hour. So I like the longer format. I appreciate you hanging in there. So for listeners, if you enjoyed this content and you like the information you got, obviously give us a review on wherever you're listening to your podcast, and stay tuned for more episodes. And maybe we'll have Dr. Miles on in the future at some point. Okay.
Thank you so much. Appreciate you and the work you're doing and the message you're sending out into the world. It's really important to have these more nuanced conversations. So thank you for doing that.
Yep, you got it. So everybody, thanks for listening to the Thyroid Answers podcast, and be sure to share it with your friends and family and give us a nice rating with lots of stars. All right, everybody, take care. Dr. Miles, take care. Have a great day, and we'll sign off. Take care.